Good morning, everyone, and welcome to a meeting of the Integration Joint Board Performance Audit and Assurance Committee. My apologies for the late start. I'm afraid I had a puncture this morning, so if I'm a bit breathless and confused, I hope you'll give me some leeway. To start off with, have we any apologies?
Yes, Chair, we have apologies from Stephen McAllister.
Okay, thank you. And do we have any declarations of interest? I'm seeing no hands and no nods. So we'll move on to the minute of the meeting of the Performance Audit and Assurance Committee on 16th January. That's pages 3 to 11. Now, first of all, can we agree those as a correct minute?
Agreed.
Agreed, thank you. And, sorry, Roger?
Thanks, Chair. I hope this doesn't come over as too pedantic, but I asked a question, as noted on page 7, about the way that falls in care homes had been reduced by regular physiotherapy exercise, and how this had been also used in housing with care complex in Tiggards, and Caroline answered the question talking about additionality in housing with care, and I'm not sure that is reflected accurately in the minutes, because my understanding of the response was that Caroline would look into the additionality of the service that was previously in Tiggards.
Okay, thank you. Caroline, do you want to? Oh, sorry, there you are. Do you want to make a comment on that?
Middle one.
Middle one, yes.
Wait till it goes red.
Thank you, Chair. I'm not actually sure what particular part Roger's referring to. I don't know if you could maybe be clear about what question it is. Is it an action point, or just so that I can pinpoint it, Roger, please?
It's on page 7, 4th paragraph down. It says, following a question around falls prevention work in housing with care complexes, the head of community services advised, and obviously that was me asking the question, and my hearing of the response from you was, you said the additionality in housing with care in the Tiggards complex was going to be considered or reconsidered, or something along those lines. I'm using the word additionality with housing with care.
Yeah, go ahead. No.
Turn it on.
You need to turn it on, turn the microphone on and wait till it goes red. That's the protocol.
Thank you, Chair. I think if I recall right, this was a discussion with regards to falls, wasn't it?
Yes.
Yeah. And I think if I recall right, you were asking, was the staff being on site impacting on the response to falls? Is that right, Roger? No.
It relates to the discussions that we've had about the introduction of regular exercises for people in the care homes and our local care homes, reducing the level of falls, and how this has happened. This same exercises have been done in housing with care in Tiggards for a number of years, and how that should continue to continue reducing those levels of falls and the risks in housing with care as well.
Thank you, Roger. Caroline?
Thank you, Roger. Obviously, part of what we're doing right now is we're because of the recent changes within housing with care, we're monitoring number of falls, so I wasn't sure if the question was regarding that. So thanks for the clarification. In terms of exercises happening within all housing with care units, it's part of what we look at in terms of the social activities that is planned by by actually the tenants within the housing with care units. It's something that's replicated across other units that don't have housing with care on site. So it's something that they pick up, and there's different ways you can do it in terms of accessing community groups and bringing them in to provide that support. And it's something that the team manager from Housing with Care is actively looking at to ensure. So it's not been uniform in terms of how it's been delivered. So we're just making sure that that is something that we're promoting within the housing with care units, but it's actually up to the individual tenants to decide what the activities are that they would want on site.
Thanks, Caroline. And that's clear. I guess the point was that the minutes don't actually reflect what that response which you've just given us. Thanks.
Okay, thank you, Roger. Thank you, Caroline. Are you happy to amend the minutes accordingly?
The minute of today's meeting will reflect that this discussion has taken place.
I think it's a more general interest that I have in terms of the expansion of that really good work that's gone on, but that's not a matter for arising on the minutes. We'll maybe take that up separately. Okay, otherwise, are there any matters arising from the minutes? Or any inaccuracies noted in the minutes? Okay, we'll agree the minutes then. We'll move on to item 5, which is the Falkirk IJB external audit plan. And I believe we have Gillian with us today to speak to this report.
Good morning. It's actually Pauline that's going.
Oh, sorry.
The report.
Bad information.
That's okay.
Good morning, Pauline. I can't actually
morning.
see very well when things are at the screen at the other end. Who it is?
Okay. Good morning. Yes. So the paper I'm bringing to you this morning is our annual audit plan for the year 25-26. The plan is in a similar format to that which members will have seen in previous years. So just a couple of things to bring to your attention. Paragraph 5 of the plan, we outline the scope of the audit, which is in line with the Code of Audit Practice and relevant accounting and auditing standards. And you'll see there the bullet points, we outline the specific areas that we'll cover as part of the audit. And you'll see that as well as an audit of the annual report and accounts themselves, we also report on the arrangements in relation to the wider scope areas that are required by public sector audit in Scotland. And we will conclude on the arrangements in place in our annual audit report at the conclusion of the audit. If we move first of all to Exhibit 1, just to bring to your attention here, this table outlines the materiality levels that we apply to the audit work that we carry out. Our overall materiality is 6.5 million, and that's based on 2% of gross expenditure. We use the figures from last year's accounts just as a approximation. Once we receive the unaudited accounts for 25-26, we'll update that, but it will remain as 2% of gross expenditure. We also have a level below that, which we refer to as performance materiality, and that is set at 4.5 million. Essentially, that's a trigger point for auditors. So when we're carrying out our audit work, if we identify any errors or any misstatements that start to approach that 4.5 million level, we would take a step back and consider whether there's any additional work that we need to do to assure ourselves that errors won't breach the overall materiality level. And then finally, £260,000 is the reporting threshold. So that's the level at which I would bring back to this committee in the annual audit report any errors or misstatements that exceed that level. Just moving on to the next section of the report, we carry out the start of the audit every year. We carry out an in-depth risk assessment as part of our planning procedures. And from that risk assessment, we identify any significant risks of material misstatement in the accounts themselves. And you'll see there, it's similar to previous years, we only have one significant risk. And this risk is a standard risk for all audits. And it's required by the auditing standards to be included in all of our annual audit plans. And it essentially relates to the unique position that management are in and their ability to override the systems of financial control that are in place. You'll see in the second column, we have a number of procedures that we carry out through the audit. and those are similar to in previous years, and that's to assure ourselves that there hasn't been any override of the controls in place. And again, we report on our findings from that work at the conclusion of the audit. The next section covers the wider scope and best value areas. As I mentioned earlier, the scope of public sector audit in Scotland is wider than just an audit of the financial statements themselves. And there's the 4 standard areas that we cover as part of our audit work. And in the annual audit report, the conclusion of the audit, we will report on the board's arrangements in place to achieve those 4 wider areas, including best value responsibilities. The last section of the report, we outline the timetable for the year, aiming to conclude the audit in November, so come back to the 13th of November committee. And we also outline the key dates to enable us to achieve that. You'll see, and you'll recall from previous discussions we've had, you'll see at paragraph 27, we outline that we will not be able to sign off by the end of September, which is the target date that the Audit Scotland has and is the statutory date for signing off local government accounts. And that's to do with the prioritisation that we have in place at Audit Scotland, whereby we prioritise the council audits and health board audits because they provide assurances to other bodies. So we have to do those first before we're able to sign off the IJB, which means that we're not able to sign off by the end of September. You'll see there that we are aiming to deliver by that target date by the end of the 5-year audit appointment. So this is year 4, the audit appointment, which means that we will need to engage with management to discuss how we plan to sign off by the end of September for next year, which is the final year. And I think perhaps a bit of a discussion about the timing of audit committees. So we're aiming for the November audit committee. There was a feeling that we could have signed off in October, but the 2nd of October audit committee was just a little bit too early for us with the lead-in time for papers. We do have a team who will be working on the audit throughout September, so we expect the majority of the work will be done, albeit we won't be able to sign off the accounts until November. But as I said, we'll be discussing with management throughout the year how we get the timetable back to sign off by the end of September. So I'm happy to take any comments or questions members may have on the plan. Thank you.
Thank you, Pauline. Anyone got any questions or comments? I don't see any. Can I just check? I mean, I've been conscious over the whole time I've been a member of the IJB that there are issues about the dates of reporting on audits and slippage there. You've mentioned that there's going to be some discussion about the date of the audit committees, the performance audit and assurance committee. Are there ways in which we can adjust our dates so that deadlines can be met? Or is that part of the conversation?
So I don't know.
Marie?
Pauline will probably want to come in. So I suppose it's more about their ability to meet those deadlines.
Yeah.
Last year and this year, certainly. From my perspective, it hasn't caused any issues, to be honest. And it's just fed in with their timing. So for next year, when Pauline's trying to get back on track with those dates for sign off for September, we'll certainly be linking in with them about what our committee dates can be next year for that. Don't know if Pauline wants to add anything. Thanks.
Do you want to add to that, Pauline, or are you happy with that?
No, that's fine. Happy with that. Thank you.
It just seems to be a pity to keep on saying every year, I'm sorry, we're not going to quite make it, but we'll try better next year. So let's hope that next year it does get back on target. Any other questions, comments on the audit report, the audit plan, sorry? No, in that case, can we go back to the recommendations and say we have noted the content of the report? Yep, thank you very much. Now we'll move on to item 6, page 32, the performance monitoring report for quarter 3. And I believe that's Callum that's going to pick that up.
Yes, thank you, Chair, and good morning, members of the committee. I'm here this morning to present the Performance Monitoring Report and, of course, take any comments or questions that you might have. Performance is reported up to December 25 and with a year-on-year comparison where possible. And there are detailed exception reports and for the following areas. So we have Emergency Department 4-hour access compliance, we've got delayed discharges, we've got attendance management across both NHS and Council Health and Social Care Partnership Services, and we've got psychological therapies waiting times. So that's the exception reports we have. I'm not going to go into great detail across all of those areas, but there are a few areas that I'd just like to highlight to the committee. So firstly, the Emergency Department 4-hour access compliance, the data showed a year-on-year increase in the percentage meeting the target. However, it should be noted that that has largely been a result of a change in the definitions and what should be included by Scottish Government. That said, without that change, the compliance would still have seen an increase, albeit a more modest increase of around 2.5% rather than the almost 10% the change in definition results in. For delayed discharges, the December 25 year-on-year performance is encouraging. There were 54 total delays at the end of December 25, and that's compared with 81 at the same time the year before, and that equates to a 32% reduction year on year. I know there is a delayed discharge deep dive paper later on in the agenda this morning, and that's going to go into more detail on this, including some of the work that's had an impact, including shifting the balance of care and investment in further assessment capacity, for example. The report details the latest position for sickness absence across both Falkirk Council and NHS services attached to the partnership. The data shows that for NHS services, there's been a 1% increase in sickness absence comparing December 25 with December 24. And for council services, the absence figure for the first 3 quarters of the year remains similar to the equivalent period the year before. For both partner organisations, absence remains higher than the organisational targets that exist. What was previously the complaints and feedback report can be found starting at page 59 of your packs, and that provides information for the period October to December 25. The report details there was 31 complaints received via the council complaints handling procedure and 286 complaints received via NHS complaints handling procedure during the reporting period. It's important to note that the NHS figure now includes the prison healthcare complaints, which until recently were not included. 12 people took the time to provide positive feedback directly to Falkirk Council services during October to December 25, and the equivalent figure for NHS services was 29 people providing positive feedback. That's a quick overview of the report, but in terms of the recommendations, the board is asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you for listening to my update, and I'm very happy to take any questions or comments you might have.
Okay, thank you, Callum. Any questions? Alison?
Hi, everyone. I've just got a couple of points that I wanted to raise. So first of all, it was just very pleasing to see the year-on-year difference in terms of the delayed discharge. And I think it is worth just noting that, because I know how much work has gone into managing those figures. And I think just seeing them on that comparative basis is very helpful. So I'm just a very positive well done to everyone for the work that has been done there. And to one question about an area that did surprise me, and then just an area of concern. So the question about something that did surprise me was the telecare figures on page 48 at item 77. Now, they haven't moved much, but they have gone down a little bit. And given the direction of travel that we're moving in, that surprised me, because I would have been expecting some of those figures to go up as we move to trying to shift that balance of care. So I'd be really interested to know how we are trying to make better use of technology to support individuals in their home and are we making most use of technology to do that? So that's question one. And the second piece was obviously about attendance management, and I know this is a massive conversation certainly in the NHS. I'm assuming it is also in the council given the budgetary impact of this, and it's really just to get some confidence from the executive team about the steps that are being taken to manage this, given the impact it has both on a budget perspective but also on a patient care perspective.
Okay, thank you, Alison. Callum, can you answer that, or should we be asking someone else?
I'll come in quickly on telecare, and some of my colleagues might want to expand on that. But I think the decrease we see there is very modest. We do see that figure fluctuate as well. There are some months or some quarters where that would increase quite a bit, and then it comes back down again. So, in terms of we do monitor the variance there, and there has been occasions in the past where we have brought exception reports when it has dropped, but performance has came back up again. I don't know if anyone would want to add to that.
Has anyone anything to add to that, Marie?
So I was just going to add around telecare. We do have a tech spend to save fund as well. So some of the team are looking into how we might utilise tech in a better way around providing care in better ways. Caroline might want to add a few comments around that. I'm not sure, but that tech fund is there. We will be bringing forward some proposals around that as well. It is a spend to save fund, so obviously we're looking to make sure that we've got future savings through that as well. But that fund is there, and we will be progressing that, and we'll obviously bring some information back about that at the time. Thanks.
And I guess that's what I would expect to see, and that's why I was a little bit surprised that it wasn't moving more. Thanks, Marie.
Okay. Caroline, do you want to add to that?
Thank you, Chair. Just to provide reassurance, it's something that we're actively looking at. So we've actually had a workshop recently, really to look at some spend to save projects that we think would be quite beneficial, but also considering as a partnership what our approach should be, so that developing a clear strategy around it. And that's something that we plan to take through governance. So, for example, one of the areas that we're considering is around that kind of prompting of medication. So there's a lot of people that perhaps only out of their 2 visits, it's perhaps just prompting of medication, and we think that technology should be explored around how you could augment what is currently provided. So it's not a technology only approach, but what it's saying is technology first approach, and then we need to develop our both assessment pathways and our use of technology around that, and build confidence as well. So some of what we're looking at is how do we showcase what's available and partner with organisations. So one of the things we're exploring is perhaps possibly looking at working with the Carer Centre around some of the work that we could do to build confidence around use of technology, so that we're getting the messaging right, but also we're getting feedback around how we develop that and embed it in our approaches. And we see that certainly for hospital discharge, that's a clear opportunity around how we could perhaps support people to look at technology first at that point, particularly for people that have never had care before. That perhaps this would be a better way of doing it, and what we recognise from the research is it isn't just about economics. It's also about flexibility of service. So not everybody wants someone in their house, and they would be open to other ways of support being provided. So that they're all things that we're considering, and we plan to bring forward shortly in terms of what our approach is in the particular projects.
That cover all the issues you raised, Alison?
And it was just that certainly on the telecare, it was just the attendance piece I would like to just cover.
Right. I think Gail wants to come in on the attendance.
Yeah, thank you and good morning. Yes, I think that's a really key point around the attendance. It's something that we're very aware of, particularly in relation to the correlation with our financial position. There's obviously been some really good pieces of work done across our NHS Forth Valley side around looking at our staffing levels and bringing in supplementary staffing to reduce agency, for example. So it's an area that we're going to be bringing into our finance oversight group to make sure we've got that focused attention to what our performance is and the measures being undertaken to improve that. In addition, we do obviously use the various HR processes and support that are available to make sure we're providing the right support for people who are off for a longer period, and make sure we're monitoring regular short-term absences to make sure that we're understanding the reasons and we can put the right supports in place. So there is support from both NHS and Council HR around that as well.
Okay, thank you. Does that satisfy your question, Alison?
Yes, thank you.
Okay, thank you very much. I think I have David, Dr. Heron next.
Thank you. Councillor Hannah, can I just check, is this a public meeting?
Yes, it is. It's live streamed.
Okay, that's fine. So, you know, as a resident and a doctor and a patient in this area, I think there's two things that glare out at me in this report that really cause me significant concern. The A&E figures are not improving. They haven't improved year on year for quite some time. The numbers attending A&E is between about 150 and 200 a day. That's been fairly static, but the figures of meeting the 4-hour target have not improved at all. The one thing that really worries me about that is, and I think I've read this correctly, 15% of people that attend A&E leave without clinical assessment. That's a huge number. And to give you a person in Forth Valley who I came across this week, got a large laceration above their eyebrow, about 1.5 inch long laceration above their eyebrow, playing sport, attended A&E and waited for 6 hours before leaving without clinical assessment. Now, that person cannot get care anywhere else in our system. They have to be seen in A&E. It's about a half-hour job to deal with them, to clean the wound and stitch them up, or a 15-minute job if they don't need stitches. But that person left without without clinical assessment. I don't think that's acceptable. So I think this committee should be seeking something that provides us assurance that that's going to improve next year. Some kind of report into what's going to be done that's going to make sure that improves. Of these 15%, quite a lot of them have some kind of triaging by a nurse, some kind of bloods taken and investigations done. None of that's ever reported. So the only thing that comes to the GP just says left without clinical assessment, no information. But I know from talking to these patients, somebody, I think a nurse in A&E, has spoken to the patient and said, oh, you're probably going to be waiting for ages, you're probably okay, why don't you just go home? If that's advice that's given to the patient, I want to see that on their discharge letter. At the moment, I don't see it, and I think that's a clinical risk. So that's one area that really concerns me in this report. The other area that concerns me is a wee bit more straightforward. It's the readmission 28 days after discharge. Again, these figures have got worse, not better. I think we had assurances last year and the year before that these figures would improve, and they haven't. They've got worse. So again, I think we should be, you know, what are we going to get in terms of assurance that next year that figure will be better? Patients coming out without an immediate discharge letter, the first step is making sure 100% of patients come out of hospital with a discharge letter that's available to their GP and any other people involved in their care. Then there may be, I think there will be work on top of that to improve that data. But it does ask questions about how people are discharged from hospital, and are they ready for discharge, and are they safe to be discharged, and are they discharged with the appropriate things in place so that they don't end up back in hospital within 28 days. So yeah, I feel like I just wanted to make these 2 points. I don't think it's a question of Callum, really, unless I've got my data wrong from reading your report. Thank you.
Okay, thank you, David. I'm really glad that you've raised the question of the 4-hour access and emergency departments. I was going to raise that myself because I think there are generally a lot of concerns about the waiting times at accident and emergency, and the examples you've used are very worrying, and add to that the fact that there are a lot of people who say they won't go to accident and emergency when really they should, because they're aware of the problem. So I think we do need perhaps to have a deeper dive into looking at what is being done and what could be done to improve that situation. But I'll pass over to Gail to come in on that point. I just wanted to get my tuppence worth in first.
Yeah, thanks. And I think David and yourself, you're both correct. This has been a really sticky part for NHS Forth Valley for quite some time, and obviously that does impact on patient care if there's long waits and if people choose to go somewhere else or not receive the care they need. So there's obviously it's really important to recognise the 4-hour access standard is an indicator that signals performance across the whole system. So it's broader than just what happens at the front door. So in terms of making sure they've got the right capacity in the community, including GPs, including social care, etc., is as important as making sure we've got the right capacity at the front door, is as important we've got the right capacity in the flow across that downstream in the hospital as well. So it's an indicator of our whole system performance. There has been a huge amount of work underway, as you would expect, around how we can improve our performance, and we've been developing and implementing what we call our urgent and unscheduled care plan across Forth Valley, and there is a report coming to NHS Forth Valley Board on that later this month, and the intention would be to bring that into both IJBs as well, because it is a whole system issue. Some of the parts of the plan include the shifting the balance of care. So and again, we're seeing the impact that's having on delayed discharges and the additionality in relation to community social care capacity. Again, we can see the impact that's been sustained, and I'm sure we'll talk more about that when we come on to the delayed discharges. So all of these parts of the system are really important to get right. We hope that the additional investment, we don't quite know what that'll be used for yet, but into general practice will also help make sure we've got the right capacity in the community to support people at the right stages. So what our intention would be to bring that urgent and unscheduled care plan into IJB, probably the next cycle, so you have that oversight and you can understand more about the different elements of that and what we expect these different elements to result in terms of impact on various indicators. In terms of the discharge letters, again, David raises a point that's been an ongoing issue. There is ongoing concerted work, and it's really important that the communications across our whole system are as good as possible to make sure people can get the right care and support. So that communication between what happens in an acute hospital and the ongoing care provided by general practice is really important. So there is ongoing work to help improve the discharge letters. And in terms of readmission rates, again, that's something that we pay very close attention to. So I'm suggesting that when we bring back that urgent unscheduled care plan, that'll provide a little bit more granular detail in some of the work that's ongoing and where we expect and where we are already seeing that impacting.
Could I just add to that? I mean, it's not just about improving the discharge letters. I don't think that was the only thing David was saying. Sometimes the discharge letters aren't getting there timeously. I think that's an important part of the process as well.
Yeah, so when I say
correct me, David. Sorry, I think David wants to come back in on that point.
Yeah, sorry. I mean, Gail makes a very good point about it being whole system issues, but I think the two case examples I gave, somebody is getting a head laceration, that is core and easy general A&E work. That patient should be seen and discharged within 4 hours. That patient shouldn't be left to wait for 6 hours and have to self-discharge. You know, that is not to do with whole system pressures. The volume of people going through A&E is not increased. The staffing levels have increased over the last 10 years, and that is just core A&E. That's not suitable for minor injuries. That has to go to A&E because it's a head injury, and it's straightforward A&E work that should be seen and discharged. And the second issue that I raised was about the no information being forwarded about people that are discharged against that self-discharge who have had investigations. Again, I think that's just core A&E work. and it's nothing to do with the whole systems pressures, but I totally agree about the whole systems pressure being an issue. And the other thing is that the IDL stuff, yes, the IDL, if the IDLs are improved and we do get 100% of IDLs going to the right people, that will be a great start. But I think that is only the start. I think this indicates bigger issues within the way people are dealt with and discharged, and hopefully the IDLs is the first step in really improving that readmission rate. Thanks.
Okay, thank you, David. I mean, I think that's, yeah, the stubborn nature of these issues that you're raising say that there's a really deep dive required here. Can I check, Gail, that in the report that you're covering, you'll be covering some of these issues, if not all?
We can make sure that we do.
Yeah,
pick these
I
up
think it's
when it
important.
comes back. I think it is. So this is really, it might sound quite simple things to resolve, but it is complicated and complex, and that's why it is taking the time that it's taking to make the improvements. So it's not something that's really simple to do.
I think we all accept that nothing within the health and social care system is simple and straightforward, but that does not mean that we shouldn't be tackling it with vigour. So I think if you could ensure that you're including within the reports that are coming a really good look at some of these issues, I think that would be very valuable. I think Councillor Flynn, I think you were next.
Yep, thank you, Chair. Yep, thank you very much. Sorry about this, but I'm going to follow on about the same subject, particularly the concerns raised by Dr. Hearn. I'm extremely concerned by the numbers that in various senses. First of all, it's easy to set a target, and I know it's set by other people, but 95% is unachievable. I mean, if you're 40% behind that target, then quite clearly there's something sadly wrong. It may come in a future report, but this is a subject that's cropped up numerous times over the time I've been with the IJB, and I get regular feedback from constituents about concerns, etc. And I think one of the general points I would make is having experienced it myself, but hearing people that, and it's not that it's wrong, but staff are quite happy to tell people, oh, by the way, you'll be here 7 hours at least, you know, and that's not a positive reinforcement of somebody that's worried about their illness, health, or accident, or whatever. I would like to see, and it may come in the report, it's fine to say that 54% of people met the 4-hour target, but how many people waited 5 hours? How many people waited 6 hours, 7 hours, 8 hours, 10 hours, 12 hours, and so forth? We really need to get that detail in front of us, because if we don't have it in front of us, we can't deal with a problem. We can't find a solution. And also, it'd be nice to see, and I think Gail's touched on it in a future report, some action. Dr. Hearn essentially highlighted the fact that really nothing's changed in a major way over a number of years, and clearly it should be changing. It should be changing. And one of the ways it can change is better communication with patients who are sat in the waiting room thinking, well, you know, is it me next? Who's happening? Whatever. And I know they go through triage, and then it moves on from there. So certainly more detail. And I think, well, nobody has, but I think we shouldn't underestimate the concern about this, because it affects health and well-being. I've seen myself, patients get up and leave, you know, after waiting 5, 6, 7 hours in the A&E and going out. And as Dr. Hearn says, you know, it's not right. You don't know what these patients are going to be suffering from then. I know it's a challenge. I don't deny that, but we really need to get down to the nuts and bolts of accurate numbers, not just saying, well, the percentage target is 95%. We've achieved 54%. Right, next subject on the agenda. It's not good enough, and frankly, it isn't good enough. This is a major subject there, so I would appreciate, Chair, that any urgent report covers these details, and any future report should be given the details. You know, I wouldn't get away with it in a previous job just saying, well, that's what I achieved. What am I doing? Well, wait and see. I have another point about another article, another point on the report, but if anyone's any comments on that particular aspect, first of all, Chair, thanks.
Okay, thank you, Councillor Flynn. I think I'll maybe ask Callum to come back in on that about the data. I think it's a well-made point that, and I was actually going to raise the question about the targets, because there was reference to some of the perceived improvement is because of changing the targets, which I think is also worth having reference to. But in addition, looking at the data that we are collecting, which are not just about how many met and didn't meet that target, but other details about the waiting times. So are you able to come back on that, Callum?
Yes, so just to give assurance that that data absolutely does exist, and I'll make sure that we have a fuller distribution of the length of wait in the next iteration of the report. We can absolutely do that.
Okay, thank you.
And would you like to make a comment about the change in definitions? Because I was a bit unclear. How have they changed the definitions that makes it look better?
So they've taken out planned attendance at emergency department. So that is the difference. Now, frustratingly, we've actually seen that change twice. So it was taken out and added back, and taken out and added back at national level. But so the change in definition shows that it's a roughly 10% increase in performance, but actually, and maybe didn't pick up on that, but the point I was making earlier was that even without that change in definition, there was a more marginal improvement in performance, but certainly not to the degree that of the 10%. The 10% was largely down to that definitional change.
Okay, thank you, Callum. I think next we have David McNiven.
One more point.
Sorry, Jim.
No,
Sorry.
Thank you. It was really regarding the absence 4.11, seeing that our absence rate is 10.25%, which is incredibly high. I would actually like to know how we compare with other IJBs, and also what positive activity has been done to identify what these individuals are. Long-term illness, I can understand. Serious illness, I can understand. But we need to know what percentage of the people are in that category, and the others are 2 and 3 day illnesses, etc. Because again, it's a number that I've raised numerous times, and it doesn't seem to be improving dramatically.
Thank you for that. I think Tom wanted to come in on that one.
Yes, I may. If I may, Chair, I wanted to deal with a kind of former problem in terms of what you've got is a universal figure, the kind of 4.5, which of course speaks of a much different demographic than broadly we have in some of the challenges around about health and social care. This has been a universal problem for as long as I can remember. However, maybe more helpfully than that observation is that prior to COVID, there was a significant piece of contextual research undertaken that established that around about 7.5% was a reasonable benchmark for the contextual element of the demographics of health and social care employees, as opposed to counting them against a much broader range of people who work within other council or NHS services. So it would be fair to say, of course, 7.5% is far higher than 4.5%, but it seemed a reasonable at the time benchmark. We are obviously above that. So I think the challenge is for us to either acknowledge that kind of thing, do a bit more research, and understand where we actually sit in what might otherwise be a reasonable benchmark, or accept that one. And then address the differential between those two. The problem is at the moment we're trying to address a presumed differential that's impossible to meet versus we have no idea what we are in context. So I think it's around about 7.5% is where we ought to be aiming at. But again, that's not for me to decide. I guess that's for people to say, is that acceptable, and how do we validate that?
Yep, thank you for that. That's useful. Thank you. Good insight. Thank you, Chair.
That's certainly a useful insight, but I think it still begs the question of what are we doing about it? And I think that's the key question. What are we doing, and are we improving things? Sorry, right, David McNiven.
Thank you very much, Chair. Yesterday, I happened to have a discussion, having read this section with Tom and Callum. So they helped me understand a fair bit about the report and its potential new structure. The report, as I see it at the moment, is too numerical. We're in a people and caring business, and it's just about numbers. The fact that we've had a healthy debate this morning on this, I think, demonstrates that what's written, people are trying to analyse and understand more, and maybe the presentation should change a bit. You know, at a personal basis, as a user rep, I'd like to just support Dr. Hearn's comments on the 15% that weren't clinically assessed or treated, having been at A&E. That provides additional pressures on our general practitioner service, and that, to me, whilst it might be a whole systems approach, there's an opportunity to redesign that and perhaps even look at supply chain management issues. I'm surprised if we have a substantial increase in manpower resource in the hospital of consultants and the numbers stay the same, why we still have those statistics presented to us. So the discussion I had yesterday was hugely informative. I'd like to raise just another couple of things, but I think there's an opportunity to redesign this report and make it more meaningful and understandable. The issues are perhaps directed at Marie, but the sickness absence, I agree totally with Jim. We need a breakdown in long-term and short-term sickness. I'd like to know what the cost of that sickness is to the organisation. And how we manage that with the use of bank staff or agency staff, and what's our well-being offering to staff to keep them in work or support them to various stages of their working lives. Thank you very much.
Thank you, David. I think Gail wants to come in on that one.
Yeah, I just want to respond to David in terms of that. You know, does the report do what it needs to do from a IJB perspective? So that's something that we've been discussing as a senior team, and I think we're probably of the same, or we are of the same view that it's something that's built up over time for the best of reasons at the time. But we've changed as an organisation. Our portfolio is much broader, so we're planning on doing a session with IJB members at a future IJB development session, so we can understand actually what would be helpful from an IJB perspective, from a PAC perspective, to provide the assurance around performance. We're also looking at that from a managerial and operational perspective to make sure we've got that golden thread across our performance, to make sure it's helpful, it's articulated and presented in a way that helps everybody understand what that changing picture is. And I think your points around being person-centred is really important. We are a people organisation, that's why we're here. So getting that balance, we need to have the numbers, but we also need to know actually what impact does this make to real people. So just to confirm, that's on our plan, and your comments are really well made.
Thank you very much. Thank you.
Okay, thank you, Gail. I think Marie wants to come in on this as well.
Yeah, thanks, Chair. David, yeah, around the costs. So I don't actually have it right in front of me right at the moment. We do get regular updates around the council cost because that's part of the kind of reporting system, but I can certainly get more detail for you around the NHS cost and share that. But as Gail mentioned earlier, we are planning to do a bit of a deep dive at the Finance Oversight Group on this, and we do monitor that agency spend over time as well. So there's been a fairly significant reduction in the NHS side of the HSCP around agency staffing, and we are monitoring that in the council side as well. We have a number of safe staffing issues in long-term care units that we have, where we have those safe staffing levels, so we must have those staff in place. But we're looking at what we might do around, taking on additional staff rather than use agency staff and things like that. So we are keeping an eye on that, and we can certainly bring back some information on that once we've done that focus at the Finance Oversight Group. Thanks.
Okay, Chair, may I just have supplementary to it? I mentioned it yesterday, and I don't know whether it's something to do with the construct of the reporting system. But what in section 5, what does 5.1 and 5.2 mean?
Sorry, could you make reference to the page number you're on?
36.
Get myself to the right place. Can somebody answer that question, Marie? Come on.
So I suppose that the finance section, David, there's no anything specific around finance there. So what it's saying is the management of performance is critical to managing the resourcing of services. So I suppose that's more a strategic intention or a strategic a statement saying that we recognise that performance is linked to resources. Obviously, we bring risk management and performance into our budget papers and our budget monitoring papers. So we'll link those, we'll link those in those papers as well. So it's more just an intention and a nod to the fact that these resources, it absolutely affects resources and that we need to consider that overall. We can certainly, part of those development sessions, have a chat about how you might want that expanded or any additional information you might want added in there specifically going forward.
There must be a real financial implication if we have 10.4% absence rate in staff. And I don't feel I understand that or we have a handle on that.
Yeah, I totally understand your point and take that on board. Obviously, that's the reason that we're going to be looking at that through the Finance Oversight Group, and certainly happy to bring something back and perhaps expand those sections around that. But, if we're looking at making improvements to the performance report and adding additional information that will help members to understand the impact, then we can certainly look at adding in some financial information around that as well.
Thank you very much. Thank you.
Okay, thank you very much. Yes, I think Tom has his hand up.
I do. I so just on that last point there, I was saying to David, I was talking about this with yesterday, David. In some respects, we have grown quite away from when that would actually just have been a statement as a placeholder to refer to the fact that performance of finances is in another space. So we do report on the performance of our financial situation, etc., as we do in terms of workforce planning. However, I suppose over time we're beginning to realise that those two things can actually be quite distinct. That yes, there is a financial performance, and that is a separate report from this performance report, but reporting on the financial aspect of the performance within this report probably also needs its own bit in there. So we were discussing yesterday, we probably need to rethink what goes in there, just as Marie was saying. But again, that's part of what Gail was referring to in terms of we're really beginning to kind of motor and grow through Helen Russell and Callum, etc., about how these reports start to communicate to members in more meaningful ways. Thanks.
Okay, thank you for that clarification, Tom. Any other questions, comments? Okay, I think we've thoroughly considered and commented on the content of the report. So going back to the recommendations, that we have noted that appropriate management actions continue to be taken to address the issues identified throughout the reports. But I think we need to add a recommendation that future performance reports should give more detail about the waiting times. I think that was one of the things that was raised there in terms of A&E, and more detail on the discharge process and readmission process. Is that fair comment to add to the recommendations? I'm not seeing anyone disagreeing. And the other thing was, sorry, Gail, yes?
Yeah, I was just going to suggest the first one putting into the next performance report, but the information about the discharge and readmission process is probably more appropriate for the urgent and unscheduled care report that I spoke about rather than the performance report. So we'll still bring it back, but through a different
To a
mechanism.
different route.
Yeah.
No, that's fine as long as it's coming back. The other issues were about the absences and including more detail in the performance report about the impact of absences in a financial sense. Is that a fair comment to add that, Marie?
So I think it would be useful at that development session that we've mentioned, if we could, we'll discuss that with members and think about what's the best information, or should we include that in finance reports, or should we include it in performance, or both. So I think at the development session we can certainly discuss that with members and look to bring back whatever might be the most informative for them, if that's okay.
Okay, so for these recommendations we would say that committee is keen to have more information on the costs of absence and will not specify where that information should be included. Is that fair comment?
Thanks.
Sorry, David, you want to come back in on that?
Yeah, just from a user's perspective, if we have these shortfalls, how is that impacting on our ability to deliver the services we have planned to deliver? I think that is captured as well.
Okay, I think that's maybe covered in the things that I have said. Is it? Yes. I'm looking at Jim, who's writing the minute and the recommendations. So that will be included. Yeah.
Thank you.
So with those additions to the recommendations, can we agree these recommendations?
Agreed.
Agreed. Thank you very much. So we can now move on to item 7, which is the national reports and inspections overview.
Thank you, Chair. This is the usual report that we bring, giving updates around any national reports, or care inspector reports, or mental welfare commission reports. So since last reporting, we've had 3 national reports, the first of which is the Audit Scotland Community Health and Social Care Performance 2025 report. Some of the key messages are set out at 4.4, including integration authorities and health and social care partnerships needing to ensure that they have good quality information to fully understand their performance. And obviously we've had a good discussion around that this morning, talking about the limitations of performance information, making it difficult to fully assess performance. And the Audit Scotland have issued an interactive data tool, or they've developed an interactive data tool, and that tool shows a general long-term picture of declining performance and satisfaction. There's recommendations also set out at 4.4, including Public Health Scotland agreeing to roll out a programme to assess current measures for monitoring performance and agree a suite of indicators to support performance monitoring. The integration authorities and HSCP should understand and explain in public reports their relative performance. And also analyse performance alongside local data to support benchmarking. The next report that was issued was Audit Scotland's report around delayed discharges. And obviously we've got a deep dive on the agenda this morning, so I haven't gone into any detail in the report for that because we have that separate report. And the final one that was issued from Audit Scotland was Local Government in Scotland Financial Bulletin for 24-25. This is an annual report which looks at local government finances, and it set out that in 24-25 council's total revenue funding and income had increased by 1.3%, but despite this, councils were facing a significant budget gap and remained reliant on reserves and savings to balance budgets. Also talked about the sector reporting a collective overspend against their agreed revenue budgets for the first time in 6 years, and also increasing indications that councils were struggling financially with a 647 million budget gap for 25-6 with budgets set. And there's also continued reliance on those non-recurring measures. It sets out some recommendations at 4.12 as well, including improving the clarity and comprehensiveness of reporting around savings performance, how future revenue budgets would be impacted by investment decisions and capital underspends, and transparency of reporting in relation to capital expenditure as well. Also ensuring reserves policies are current and remain fit for purpose, and that risks to financial sustainability are included, and include the detailed scenario planning. So there are a number of recommendations there. The reports are linked in the report as well. At regional level, there's been one Mental Welfare Commission report, and Nicola's here this morning to cover that one, and we can take any questions at the end. Thanks.
Nicola?
Thank you. Yes, so there's been one Mental Welfare Commission report published since our last meeting, and that was in relation to Ward 5 at Forth Valley Royal Hospital Mental Health Unit. So you'll see from the report that the visit highlighted that there was respectful and compassionate care from all staff, and that actually all of the service users and relatives that the commissioners had spoken to gave very positive feedback about the staff. They also highlighted that there was effective multidisciplinary team working reported, and that was as an area of strength, and 4.16 details the range of the disciplines that was included in that observation. The visit also identified that there was good quality documentation and physical health checks within the ward, with appropriate referrals being made and up-to-date documentation that was evident from that perspective. There were two recommendations from the visit, and you'll see at 4.18, the first recommendation again is in relation to the treatment forums being in place that we've heard through previous reports, and recommendation 2 is to identify a robust system of auditing the treatment forums. I just want to update that following discussions with the Chief Nurse for Clacks Stirling Health and Social Care Partnership, who has the responsibility for mental health services, there is now a formal Mental Welfare Commission Improvement Group being established. And this will not only look at the reports on an individual basis, but will undertake a thematic review of all visits. And an improvement plan will be developed, not just for the individual areas, but there'll be an overarching improvement plan developed as well that will address some of these issues. I also want to highlight, it's not in the report, but following the development of this paper, a Healthcare Improvement Scotland inspection report relating to the whole of the mental health unit in Forth Valley Royal was published. The visit took place in August 2025 and explored the fundamentals of safe delivery of care. That report highlighted 8 areas of good practice, 1 recommendation and 19 requirements. Full details of this report will be provided at the next pack, and I believe the intention is also to request a deep dive on that report and mental health services as a whole as part of this process as well. I'll stop there and happy to take any questions.
Okay, thank you very much. Do we have any questions or comments? I think maybe it's just worth mentioning, given that Marie has raised the issue of financial sustainability, it's hard to say, that just for people's information, the Falkirk Council did set its budget yesterday and has agreed that the requested funding on a recurring basis that the Health and Social Care Partnership was asking for is going to be covered in that budget. So I think it's just worth a mention that people are aware of that. The details will be coming out from the Falkirk Council later on about the other issues within that budget. But for this partnership, it is important to know that at least is there. It doesn't take away from the challenges that are facing the Health and Social Care Partnership, but it is a small piece of reassurance. Any other questions or comments? Sorry, Alison?
Thank you. I just really to pick up on just a comment that was made just when we covered that report, and it was about the mental health report, and the comment was, and that is a finding that we have had before. I guess my question on this is really about how are we making sure that when we have issues, we are actually closing them off. So that we are not kind of going back and finding the same issues. Actually, how do we get confidence that when we find these issues, we are actually tackling them, when we're tackling them systemically across the whole of the operation?
Thank you, Alison. I see both Nicola and Maria have got their lights on, but shall we go to Nicola first, I think?
Thank you. Thanks, Alison, for your question. Yes, you're absolutely right to ask the question. And I think the development of that formal governance group in relation to inspection reports, that's where we'll get that action and assurance. So that didn't exist before. Obviously, with the mental health unit, mental health services are hosted in Clacton Stirling. So I've been liaising quite a lot with my counterpart there. And she has agreed to set up this meeting, which I'll be part of as well. So I can bring any learning from that meeting back through Falkirk governance routes as well. Although it's hosted in Clacton Stirling, obviously there's Falkirk residents that use that service, so it's important to bring it back through Falkirk governance routes as well. But I'm confident with that new governance group being set up and the focus that will have, then we'll start to see improvements in these areas.
Thank you, Nicola. I think Marie wanted to come in also.
Yeah, it was just on your previous point, Councillor Hannah. It was just to say, yeah, that's really helpful that additional recurring funding's been approved by the council, and the budget paper that I'm bringing to IJB on the 20th of March will reflect that. But it was also just to note that since this report was issued, the finance bulletin for IJB's finances for 24/5 has been issued as well. So that's been circulated to all IJB members, and I will be covering that in the budget paper, and it will be included in the next update for the national audit reports as well. Thanks.
And that'll be full of good news. Perhaps not. Perhaps not. Okay. Any other questions or comments? So can I say that we have considered and commented on the contents of this report? Agreed?
Agreed.
Thank you. We'll move on now to Item 8, which is the partnership funding scrutiny. And I think I have Leslie for that one.
Yes, good morning. Thank you, Chair. So the purpose of this report is to provide members with an update regarding the work of third sector partners that receive funding to provide services that contribute to the priorities of Falkirk Health and Social Care Partnership Strategic Plan. This report covers the financial period 2024 to 25 and includes a total investment of 3.625 million. During this period, the partnership operated a partnership funding programme, and therefore for completeness, all funding allocations are included that either fall within following the public pound, reporting and monitoring arrangements or procurement guidelines. As members will note, funding is allocated to a diverse range of organisations for a wide range of purposes, including enhancing provision of prevention and early intervention and supporting our ability to meet our statutory responsibilities and national and local policy objectives. Each award is detailed within the appendices, and for the efficiency of time, I'm going to highlight key points that have been identified through the quarterly monitoring process. A summary of all organisations is provided in 5.1 of the report. So from the 29 allocations noted across 24 organisations, we are recommending further review of more than 50% of these. It should be noted that the reason for further review does not always indicate poor performance of an organisation, but also can relate to, for example, the contribution of the service to the wider system, the balance of resources between areas of provision or cost effectiveness. So to provide a few examples, in relation to Appendix 2, Alzheimer's Scotland post-diagnostic support is recognised as an essential component of the dementia support pathway. While the 5-pillar model remains critical within the post-diagnostic pathway, a significant gap persists in provision for individuals living with more advanced dementia, where 8-pillar support becomes increasingly necessary. Review is therefore required to consider the balance of resources and should be progressed as part of a wider strategic review of all internal and external dementia provision. In relation to Appendix 5, Central Wellbeing provides effective low-level peer support to a range of people, and further review is proposed based on the model of provision in relation to impact and cost effectiveness. With regard to Appendix 6, the psychological therapy service provided by Committing to Ending Abuse is funded in addition to core provision. The model of delivery has varied from what was initially intended, and therefore further review is also required. There's a very high level of demand for this service, and the waiting year is currently a year. The waiting list is currently 1 year, and therefore the review should be progressed in line with wider commissioning work relating to gender-based violence. Mates and dates, Appendix 9 provides a range of opportunities for people with learning disabilities. However, it's very niche in terms of the population supported. Future review work should be progressed in conjunction with the learning disability team to consider operational effectiveness and capacity. There is also potential review opportunity for Falkirk Carer Centre and the Independent Living Association to consider the interface of these organisations have with adult social work services. It would be helpful to better understand the impact of the support on statutory provision. A final example of areas of review is indirect costs associated with service provision. So the proportion of funds that relates to management and overhead costs varies greatly across organisations. Whilst it's absolutely acknowledged that indirect costs are essential to the operation of organisations, where these costs are over 15% of the total fund provided, we need to apply additional scrutiny and consider this in future commissioning processes. In conclusion, Falkirk Health and Social Care Partnership provide a wide range of organisations funding that positively impacts on people and communities. Robust monitoring arrangements are in place that consider individual organisational performance and also alignment with the wider system. I'm happy to take any questions. Thank you.
Thank you, Leslie. Can I ask a fairly straightforward question first? You made reference to £3.625 million for partner organisations, but the report makes reference to 3.234 million.
Yeah, apologies.
Can you clarify?
Sorry, my apologies. The 24-25 figure is missing from the bottom of that table. So the 3.6 figure is for 24-25, and then during 25-26 we funded 3.234. So apologies, that's an error on my part.
Right, so that's on page 92.
Yeah.
If that figure is missing, if we could make sure that that's included for public transparency. Does anyone have any questions or comments? Okay, Tom?
Yes, slightly back to front, Chair, just to provide a small context to why this report is here today, and although it might immediately seem evident in terms of its content, there's been a lot of reporting, a lot of conversation, particularly via the IJB and in various groups around about partnership funding. But we felt that it was important for this committee to see where is the yield of the investment that is being made. So this is not about the decisions being made in the past around about the amount of money being invested in partnership funds and the configuration and the nature of all of the different organisations. This is intended to give oversight and scrutiny in relation to what are we getting for the money we are investing in those organisations to do pieces of work for us. So that's the absolute intention of today. And I appreciate that in this first iteration of this, that's rolled everything into it. We can in future, of course, come forward with deep dives into certain thematic areas or certain areas of particular interest. But this is the first iteration of this kind of scrutiny of investment report. So I hope that's helpful. Probably should have said that at the beginning, but thank you.
Okay, thank you. Thank you, Tom. Ian?
Green. Oh, yes. Thank you, Chair. Just from a third sector perspective, I do welcome the report because I think it highlights the contribution the sector make to health and social care, which is fantastic. And I also acknowledge actually the importance of further review because I think it's really important that all of us are up for scrutiny in terms of providing value for money, providing appropriate services. So very much welcome the report. I think the other thing I'd just like to add as well is one of the more recent initiatives has been the partnership meetings that Leslie and Nicola have held with partners who are funded within the partnership fund. And there's been universal support for that. It's been an opportunity for partners to get insight around the funding, but also actually to share what they're working on together and try and encourage a bit more collaborative working within the sector. So it was just a comment, Chair. Thank you.
Thank you for that, Ian. I think I would just reiterate what you're saying, that I really welcome this report. I think we must always remember to recognise the contribution that third sector partners make to the whole system. We talk a lot about the whole system. The whole system includes the third sector input as well, which is greatly valued. And so this is very much a welcome report. I think I have you next on my list, Roger.
Thanks, Chair. My job work with most of these groups, and they're really valuable services. All the ones I've worked with are fantastic. But I was just really basic question is how the different how there's balance of funding towards different service areas, carers as opposed to mental health, as opposed to people from an ethnic minority or people with dementia. Because how do we determine the right balance of supports?
Me?
So I might come in, and then Leslie might come in if she wants to add any further comments. So during the processes, I know people will be aware of the process we went through last year around partnership funds when there was a reduction to recurring budgets. So certainly part of that process was to consider the overall funding to different thematic areas. And Leslie's also mentioned those thematic reviews that we're doing as well around looking at, what is the service for dementia overall, not just within partnership funds. So it's considering what budgets do we have within services as well, and not looking at this in isolation. So we've certainly took a view moving towards next year's funding that we kept the percentages fairly similar. We didn't want to make a huge change to what the overall investment was in each thematic area. So I don't know whether Leslie wants to add anything to that, but that's certainly the approach we've taken so far. But certainly moving forward, it's about making sure that we're considering that, what is that service overall, including budgets that are sitting within overall, in operational services, rather than just sitting within partnership funds.
Thank you, Marie. I think I have David McNiven next.
Yes, thank you, Chair. I mean, the third sector gives us enormous value, and I'm just extending a bit more on Tom's comment. How do we assess the people impact of that investment we make?
Tom, do you want to come back on that, or someone else?
Well, Leslie would probably give you the best answer. I could certainly give you an answer, I'm sure, but yeah, Leslie's closer to the actual activity of the individual organisations and could give you some overview.
Okay, so Leslie?
Sorry. The approach that we take varies between organisations because the outcomes and the type of provision is very different. Some organisations are not directly supporting people, but are supporting other organisations. So, for example, CVS Falkirk. Others are directly contributing to the health and wellbeing of individuals. In terms of our monitoring and reporting process, what we do is we have a balance of data, but also qualitative information. So we look at challenges and changes, we look at achievements, we gather snapshots as well from organisations, which are helpful in terms of bringing the service to life and making sure that we can actually look at the journey of the service user and the impact. I think that in terms of early intervention and prevention, monitoring is a challenge. I think it's a challenge nationally. in terms of being able to, rate or establish tangible impacts on people, and that's why we've made sure that the qualitative information that we gather is robust.
Thank you very much, Leslie. Thank you.
Thank you, Leslie. And Alison?
And mine is really a bit of a build on that, again, it is great to see this for transparency, but also to, as the start of almost recognising the value that these organisations provide to that system. And that's really where my build comes in. And given the point that Leslie was making, I would love to be able to see some of the output of that monitoring and evaluation so that we can actually see that value. Because we're seeing one side of the balance sheet. So here we're seeing how much it is costing, but we're not necessarily seeing the value that they're adding. And what I would love to see is coming back to this committee is then that value. So what is the impact that they're having, accepting all the points that you made about the challenges around assessing some of that outcome and that impact. But I think it'd be great in future reports to be able to see some of that and to celebrate some of the impact of the third sector.
Thank you for that. I think Tom wants to say something more on that one, and then Leslie.
Leslie may well be wanting to answer that one directly. I wanted to make a slightly broader point, if that's okay. So maybe Leslie was wanting to answer Alison's point.
Leslie first, then.
Yes, absolutely. I guess this report focuses on a particular time period for 24-25, and actually the processes that we have in place have developed and moved on quite considerably since then. In terms of the overall impact, I absolutely agree with you that that's something that we would like to introduce and bring back in future reports. And what we're actually doing is we have an evaluation framework which has been developed with partners that looks at what community-based services and early intervention prevention, how they actually contribute to the priorities of the strategic plan, and the actual activities that are kind of aligning to that. So we can certainly bring that back into future reports.
Thank you. And Tom?
Yeah, just actually building on that, as we all know, organisations often exist in moments. The moment we do our strategic plan, the moment we make a decision on something. And the reality here is that our long-term sustainability will never be about those momentary decisions that we make. It will be about how we construct something that is longer term and sustainable. And I think it would be foolish of anybody to think that our long-term sustainability will be whatever we can provide through our direct funding and service land and all of those kind of commissioned and internally delivered services. It will in reality be about how we can galvanise the community aspect, the independent and private sector, the kind of the third sector. All of the galvanising of all of that activity and endeavour will be our future sustainability. So this process at the moment balances what we can afford with the intermediate period in which we have to keep the system sustainable and continuing to reasonably thrive. The next iteration of this, of course, is a much more integrated piece of work around about the third and independent sector and all of that activity and how it galvanises and has a direct line into our strategic objectives, and it is something that we all share doing, so that we're no longer in that we have a bespoke amount of money for bespoke bits of activity from individual organisations. All of this has to be collaborated with together, and I think that's the trick, is moving from where we are just now, which feels quite vulnerable and fragile, into something that everyone can feel is quite sustainable in the long term. And that includes the sustainability of the third and independent sector going forward. Because without them, honestly, we don't stand a chance. And that's the bit that we need to ensure is robust.
Okay.
That's all. Thanks.
Thank you, Tom. Victoria?
Thank you. I was actually coming in with a bit of a stamping of my foot and championing the sector, and while there's the affordability of what we provide, we are most certainly underfunded. However, Tom probably said it far more eloquently than I did. So for a Friday morning, Tom, thank you so much, because I'm sure I would have got my words mixed up. But what my point is, the affordability of the third sector is vital for your services. However, through the thematic reviews over the last few years, what the third sector has demonstrated is, in actual fact, you are getting far more added value than you are investing in us. Now, while I totally agree you have a limited budget and it's what you can afford, I think you absolutely need to realise that longevity and sustainability of these services is very, very important. So 12-month funding is a waste. Sorry, I shouldn't say it's a waste of time. We could get more value out of that funding across 3 years as opposed to a 12-month funding pot. Now, there are ways, absolutely, we must come together to work to seek further investment, but some of these services will never, ever be able to attract other investment apart from grant funding, because that is the nature of the services that they are providing. And there needs to be that long-term commitment to continue to fund some of these third sector services, because they will not get funding from other sources because they are directly aligned to the health and social care partnership strategic priorities. So we must remember that, especially, yes, we're coming into the new financial year of 26-27, but I'm already looking at the funding strategies for going forward. So it's good that we have a really good, strong dialogue between myself, Gail and Marie, and I would absolutely seek to continue that, because the third sector is absolutely a vital service within this partnership.
Thank you, Victoria. Wouldn't expect any less of you than to come in stamping your feet and trumpeting the value of the third sector. So thank you for doing that. I think local authorities and integration joint boards are kind of to some extent in the same boat when it comes to year-on-year funding, and I think that's one of the issues that has been getting raised by many of us, that longer-term plans, it's very difficult when you don't know from one year to the next what your budget's going to be. Fully understand that. I do wonder if there's a case for bringing back almost kind of presentations, whether it's through the development sessions or through reports to the IJB in terms of the activities, because I think it really is important that we recognise the value of the third sector, and just getting reports from our officers is maybe not the best way for us to get a feel for what is actually going on. But I don't know if anybody would like to. I think Marie's got her light on to come back on that one.
I was just going to say,
maybe Gail.
Yeah, I was just going to say that's probably something we can think about through those development sessions. If there are certainly areas that people want to see maybe a deeper dive, we could maybe do that at development sessions, or agree to bring something back. I suppose just on Victoria's point as well, we do have some joint working arrangements in place which are longer term funding. These thematic reviews that we're taking forward, and that, making sure that we're considering the impact across all, the operational services as well as partnership funds. That's something that we would be considering moving forward, is what's the most advantageous and most cost effective way of doing things, and how do we get the best impact as well. Thanks.
Okay, thank you. Gail?
Yeah, I just want to say it's really important to continue to recognise that the third sector is part of our partnership. They're not something different. They are part of what we aim to do, part of what we need to work collaboratively together to make sure that we're able to provide that essential support for people when they're in needs at various stages. So in terms of your comment, in terms of how can we make sure that the profile of that and the impact of that is better shared, I think if we can maybe just take that offline and we'll have a think about that, and we'll maybe just bring that into development session to think how we can best achieve that. But I think that's a really good point. I'm sure, seeing Victoria and I'm sure the third sector will be delighted to come along and share some of the good work that they do.
And thank you for that, Gail. Yes, I mean, it was a general kind of recommendation rather than having a specific idea about how it would be brought forward. It would require a considerable amount more discussion and debate about it to decide what's the best way to bring that forward. But thank you for that commitment. Any other questions or comments? I don't think that commitment requires to be actually added to the recommendations. I think we'll trust that actions will be taken and will be brought back to us. So we're asked to note the report and acknowledge progress by external providers in meeting the Integration Joint Board's priorities and consider whether to request further information on specific aspects of the service provided. Well, I think we have certainly asked for further information, although we're not being very specific. We'll leave that to further discussion. Can we agree that recommendation?
Agreed.
Agreed. Thank you very much. I think that might be a suitable point for a small comfort break. So we take 10 minutes. 10 minutes okay for everybody? So we'll come back at 11:20. Good morning again to everyone, and thank you for that break. We have covered the first 8 items on the agenda, and we're now going on to item number 9, which is the Clinical Care and Governance Management Group report. And that's page 216 of your agenda. And I think we have Nicola to cover this for us.
Thank you. Yeah, so this is a normal report that comes from the Clinical and Care Governance Management Group. You'll see the normal standing agenda items that have been discussed have raised no concerns in those areas. So all care assurance visits that were undertaken across the partnership areas returned either substantial or reasonable rates of assurance relating to the key quality areas explored. There were no unusual trends or themes highlighted from safeguard reports or care inspectorate notifications that were submitted in the last reporting period. In relation to different discussion points that were raised through the various subgroup reports, you'll note at 4.2 that the medical lead for Falkirk Health and Social Care Partnership shared that the primary care quality improvement group were exploring the creation of a website to host multiple current dashboards currently in use all in one place, and that would allow for much easier access and use of the data for improvement purposes. At a previous Clinical Care Governance Management Group, there was discussion relating to the increase of out-of-hours activity due to urinary tract infections, which did not actually require medical treatment at that time. So at the last Clinical Care Governance Management Group, the medical lead and the Associate Director of Pharmacy shared an update to work that they were progressing jointly relating to improving public knowledge regarding urinary tract infections. And this includes when and how to seek intervention. This work will include a public-facing information leaflet, which will include symptoms and home treatment options based on the latest NICE guidelines. Delays in a range of reviews were noted in the group, and these included reviews for individuals supported by social work and social care officers, people who were receiving home care, and those awaiting guardianship related reviews. And whilst these delays were recognised, teams did provide the management group with assurances that there was no significant risk related to this at the current time, and that appropriate safeguards were in place. There is work that is underway to enhance relevant standard operating procedures that will look at both system and process perspectives, and that work is being led by the heads of community and specialist services, and the management group will get updates as that work progresses. In terms of adverse events and learning reviews, I must apologise, there is a typo at 4.10. It says that there was 10 adverse event briefing notes considered, but actually there's 11. It does say in the brackets 8 new cases and 3 previous cases. Clearly I couldn't count on that day, so apologies. So of the new cases, 7 of those related to pressure ulcers, which developed within the community setting, and 1 related to a medication error, again within the community setting. One adverse event relating to the medication error was escalated to the shared intelligence group with the recommendation that a local management team review is undertaken to identify any learning that can be shared from this incident. Further down, you'll see that the management group also considered a presentation from the Keep Well manager, and she gave us an overview and a deep dive into the Keep Well service. So Keep Well, for those of you who are not familiar with the service, is a community-based early intervention service which aims to provide person-centred, health-focused assessments along with health-promoting conversations. And these are put in place to support and inspire health behaviour changes and prevention of disease. At section 4.15, you'll see the specific aims that the service has got. And the service tends to target people who are living in SIMD areas 1 or 2. So the service sends out targeted invitation letters based on GP lists and SIMD data, but members of the public can also self-refer into the service as well. So as part of the presentation, it was shared that the service undertook over 2,700 initial assessments over the course of the year, and 42% of those were for people in the target area of SIMD 1 or 2 areas. From this, over 1,000 people were referred for further assessment, and 624 people were actually diagnosed with one or more physical conditions that may not have been diagnosed without the service, and this highlights the value of the interventions. I didn't go into too much detail in terms of the presentation because it is intended that a full presentation of that deep dive will actually be presented to committee members at a future date, so you'll get to see more detail as that presentation comes forward. In terms of risks identified, so there was an ongoing risk identified in relation to mandatory training, in particular around access to resuscitation training. Since the report's been published, though, I'm pleased to announce that we have managed to secure an additional 42 courses for resuscitation training for community-based services. So that's a significant number, and they are all fully booked. So we've got the relevant people on those courses. And transitions of care continues to be raised as a risk, and I know we've had some various conversations already at committee today. I have put forward the proposal to our Director of Nursing, who is leading the development of a repeat safety collaborative, that transitions of care should be one of the core work streams in that, looking at that from a whole system perspective. So I'm hopeful that that will be accepted and we'll get the right colleagues around the room to look at that moving forward. I'll stop there, but happy to take any questions. Thank you.
Okay, thank you, Nicola. Does anyone have any questions, comments? Alison?
Yeah, two on this one. One was just about the resuscitation training. This came up on the NHS board as a result of an external review. And we had a discussion on the NHS board about some of the challenges we have in our general training figures and how much risk are we holding in that. And I think it's probably the same question back to this group, that we obviously generally report our training figures as an overall figure and a percentage, as opposed to how much of it is medical versus how much of it is and perhaps more policy related, and how much risk is sitting within that. So obviously not having completed resuscitation training is a much more serious matter than perhaps not completing corporate parenting training. Although both are important, one has more significant impacts if we aren't there. So it's really just a request to have a look at our overall mandatory training and have a look at see how much risk are we holding in terms of the medical elements of that. And is it only this resuscitation training that we've got a problem with, or are there other areas of risk within our mandatory training? So that was the first piece. And the second bit was about the I've forgotten its name. Let me just get the name. 222. It is the Keep Well service. It's really lovely to hear about this. It wasn't something I had known about, and it's great to see the stats and the uptake. The real question for me, though, is what is outcomes and so the request is, when we come back for the deep dive, is to try and give us a view of what the impact is and outcomes. I know that's really hard to do, but anything you can to be able to show not just the activity, but the income and the impact and outcomes would be much appreciated.
Okay, thank you, Alison. Nicola, do you want to come back on that?
Yeah, so I'll start with a Keep Well comment. So the annual review that you'll see in the presentation that goes alongside that absolutely will focus on outcomes for people. And there's a couple of case examples in a video that goes alongside that as well, where you'll actually hear from people who've used the services and the impact that that's had. But there is data included in that, so you'll get to see that when it comes forward. In relation to the mandatory training, just to highlight, we do examine all all mandatory training elements through our governance routes. The reason why I pulled out the resus one is that is the riskier one, as you've pointed out, for various reasons, and in particular the information that came to us through our last cycle, and I've put that in the report at 4.19, was in relation to some of our allied health professional teams who actually deliver interventions to people under a directive. So actually the directive tells them what they need to do and what requirements they require to undertake that, and resuscitation training is one of those requirements. So in order to be compliant with the patient directive that they are undertaking, they require that mandatory training. So if they don't have it, then it's putting at risk being able to deliver those interventions. So when we did highlight that, that's when we were able to get the additional 42 courses that's been put on. There was a range of courses put on, and I think the majority of them were focused on acute hospital staff, but I had asked for some of them to be community-based, and we've got those extra ones. So we do look at risk, but I'll be clearer moving forward in terms of the rest of the data and where the risk is sitting.
Thank you.
Thank you. Can I just ask on the Keep Well, because it's not an organisation I'm familiar with, how is that funded?
It's funded centrally, is it? Yeah. Sorry, I'm looking at me.
Yeah, it's part of the core budget funding, yeah.
Right. So is that part of the health and social care core budget funding? Right. Now, I probably should have known that. My apologies for my ignorance. Okay. David McNiven, I think you were next.
Yeah, thank you, Chair. It's just to build again on the Keep Well service. It's very pleasing to hear that exists and what it's actually doing. How much of a percentage of a resource is added to that service on the basis that if prevention is one of our principal objectives as laid out by SG, I was trying to liken that to being marketing of a new product in a business, where you would spend up to 15% of your income to market and sell the new product. So roughly, are we investing significant sums or small sums in this area at the moment until we learn to develop it more effectively?
I think that might be best answered by Marie.
That's a good question, David. I don't have that right in front of me right now, but I will get that for you and I'll get that circulated. Sorry.
Okay, thank you very much. Thank you.
Okay, thank you. Roger?
Thanks. I just wanted to make a plug for the corporate parenting training. I have worked in children families before I came into mental health officer for many decades, and have seen a lot of children who went through our care system die because of the lack of support that the council gave them post leaving care. So I would thoroughly recommend the training to everybody, because I do think I'm looking at Sarah, who would probably support this, that the Falkirk Council now have improved tenfold, if not 100-fold, the support that they give to children who've gone through the care system. And I think this is really, really important training for everybody. So not wanting to undermine what Alison's just said, but I do think that the corporate parenting training is really, really important. Thanks.
Sorry, I wasn't trying to say that it wasn't. It was just about what risk are we holding, was my point. It was maybe a bad example.
Yeah, I didn't take that you were saying it was unimportant, far from it. But yes, I think it is important to highlight how important that particular training is. One of the difficulties is that so many different bits of training are so very important. Does anyone else have any questions or comments? I was going to ask about the paragraph 4.2, the exploring the creation of a website to host the multiple current dashboards currently in use in one place to make it for easier access. Are you able to give me a little more information about that? Because I think one of the things that publicly is getting a lot of people interested is the whole question of digitisation.
Thank you. David's on the call. It was actually David that provided that update to Dr. Heron. I'm wondering if he would like to come in and give you more detail than that.
Okay, thank you, David. Dr. Heron, if you could.
Yeah, Councillor Hannah, I think within primary care, we already have a lot of dashboards. We have dashboards that show how many appointments we're delivering every week. We have dashboards that show how costly our prescribing is. We have dashboards that show how much pressure practices feel they're under and what recruitment challenges they're having, etc. The problem is that none of them sit on an easily accessible place. So if you ask me the question, how's general practice doing today, it's quite hard for me to go and look at all these different things and pull together a kind of a summary very quickly. Whereas if we had all these in sort of one accessible place, possibly intranet rather than internet, then it would be much easier just to be able to sort of provide a summary. A lot of information exists. It's just we don't really have it at our fingertips. So that was the idea of having this sort of one place now. Yeah, as I said, the question of whether it would be fully public accessible or whether it would be something on the intranet that's for us to interpret and then provide reports on is undecided at the moment.
And I think I wasn't talking so much about publicly accessible. I was talking about the public debate rather than publicly accessible, although there is a whole other issue about that as well. Do we have any kind of timescales that we're talking about here?
No, I think Louise McCallum, our service manager, is kind of leading that, and I would have to revert to her, but so I couldn't tell you a timescale at the moment.
No. Okay, I'd be interested to see the progress. So, any other questions from anyone? No further questions? Then we'll go back to the recommendations, if I can find them. Fairly simple: to consider and comment on the updates provided within the report. I think we can safely say we've done that. So we move on now to item 10, integrated inspection of care at home for the Falkirk Health and Social Care Partnership. That's page 224 to 272. And I think we have Daniel to speak to this report.
Thank you, Chair. My name's Daniel Stoddart. I'm the Care at Home Review Lead for the partnership. So to talk through the report, I've prepared a presentation which Cheryl is just bringing up. Thank you.
Yep, I think that's clear now.
Great.
Can everyone online see the presentation? Yep. Okay, thank you.
So this inspection was undertaken between April and September in 2025. It was a test of change inspection, so committee members will be aware that the Care Inspectorate is the regulatory and scrutiny body for care services in Scotland, and that means that the Inspectorate carries out scrutiny of the functions of local authority health and social care partnerships, as well as individual inspections of regulated care services. So this test of change inspection brought together those two elements and models of inspection to look at the commissioning arrangements for care at home within the partnership. So and answer the question that's up there on that first slide: how effectively were the health and social care partnerships commissioning arrangements contributing to good outcomes for people and their family carers? So that's looking at the partnerships arrangements for commissioning care at home services, in addition to in part measuring that performance through the outcomes of the inspections of individual regulated care at home services. So the inspection activity was significant. looked at the inspections of 27 regulated care at home services. It included the surveys of people and their family carers, with around 400 responses, staff surveys of both partnership staff and staff working in independently commissioned care at home provision of more than 500 responses, a number of kind of core discussions with people experiencing a care at home service and their family members, focus groups with frontline staff and with leaders and managers within the partnership, the usual inspection activity of reading people's case files, and in addition, surveys of more than 100 regulated care at home services across Scotland for the purposes of comparison. So the findings of the inspection were broadly really positive. So the inspection identified a number of key strengths, and those included that almost all people were very positive about the care and support that they experienced from their care at home service, and that care at home services delivered positive outcomes for people. That the commissioning process and processes were effective, well developed. There was a strong multi-agency leadership and collaborative culture that was evident across the partnership, which was supported by robust governance and strategic risk management arrangements. So this committee was referenced within the report as part of the provision of those governance arrangements. And the inspection found that staff's care practice was person-led, and that there was a shared commitment from staff, both in independently commissioned providers and within the partnership, to putting people at the centre of their assessments and care provision. In addition, there was a preventative approach, and care at home services were part of an effective framework of early intervention and community-based wellbeing initiatives. So again, referencing some of the services that were referred to in item 8 of today's agenda, in particular CVS, Falkirk and third sector interface there. In terms of market insight, the partnership showed a strong understanding of the local care at home market, and the inspection felt that the market aligned investment with our strategic priorities and commissioning goals, that effective systems were in place for monitoring performance, albeit that the sustainability of some recent improvements were uncertain due to the financial pressures. I think it's worth saying that Falkirk ranked among the highest partnerships in Scotland for levels of care at home provision across all age groups, and improvements have been made in reducing the waiting times for assessment and the delivery of service, and that the partnership performed above the national average in terms of the proportion of adults with higher levels of care needs who receive care at home, and the proportion of services that are evaluated good or better by the care inspectorate. And in addition, the workforce planning arrangements and strategy were described as comprehensive, which in a challenging recruitment environment supported recruitment and retention and professional leadership, albeit that's filling some key roles remained and remains challenging. So in terms of areas for improvement, so there were 5 areas for improvement that the inspection identified. So the first of these was relating to self-directed support. So as part of an assessment of somebody's care and support needs, self-directed support legislation means that we should offer people their care service through a range of different options, which range from directly employing the people who deliver their care to asking the local authority to make the arrangements and identify the care provider on their behalf. So in relation to the partnership's practice around self-directed support, the inspection found that some improvements were needed in relation to the more consistent use and promotion of genuine choice for people and their family carers. The inspection identified that our commissioning framework promoted inadvertently the use of option 3 under self-directed support, which means that the local authority arranges somebody's support on their behalf. So the systems and processes around offering self-directed support meant that we inadvertently kind of prioritised option 3. And the inspection felt that that led to low uptake of other self-directed support options. In relation to carers support, the findings were that the assessments of carers' needs were not well connected to the available resources, and that, for example, there was a limited flexible respite options available for people. In relation to people being discharged from hospital, the finding was that continuity of care for people after being discharged from hospital should be better arranged. And what that relates to is a practice that has been developed in the partnership. When somebody comes into hospital, if they're in receipt of care from a care provider, if they remain in hospital longer than 7 days, that contract with the care provider was ceased, and on discharge, they would then have a new care provider arranged for them. And because of the challenges in arranging other forms of self-directed support options directly from hospital, that meant that invariably people got a different care provider from the provider that they'd had before they came into hospital. So that's what that references in terms of the continuity there. In relation to performance frameworks, so the inspection identified that although the partnership was using data well, outcomes data was not routinely included, and that would have an impact on the partnership's self-evaluation activity and the developments of the service. And in relation to the pace of change in terms of the transformation and service development in relation to the in-house care at home service, the inspection identified that the pace of that change was not happening sufficiently quickly, and that might undermine the partnership's ability to deliver on strategic wider priorities. Just for illustration, this breakdown relates to the inspector's assessment of the effectiveness of accessing services prevention and reablement. So that this is based on the file reading carried out by inspectors. So you can see a strong performance of more than 80%. That was at least good performance. So 45% in relation to accessing services was assessed as good, and 36% very good, 4% excellent. So to establish that, the inspectors are reviewing case records and they're evaluating how effectively people have access to services in relation to that. So you can see for yourselves the breakdown across those other areas around early intervention and prevention and reablement. So I would say that's a strong and encouraging picture, but not one that should lead to the idea that performance improvement isn't needed. So again, this is the inspections assessment. Sorry, Cheryl, could you move on to the next slide? Thank you. This is the inspections assessment of the effectiveness of assessment, care review, and care planning processes. So again, a really positive breakdown of those different areas there from the outcome of the inspection. The national health and wellbeing outcomes are a range of indicators, national indicators that are used to measure performance in relation to health and social care, and the outcomes related to people's views from people experiencing care and their family members, and as assessed from record reading. So again, this shows a good percentage, but the bottom grid shows the greatest level of need to improve around how carers are supported to look after their own health and well-being. So carers only partly felt that they were supported, and there's a good 1/5 that people weren't sure. So again, performance improvement required there. Overall, the inspection evaluated the partnership's performance as good across all of those 7 key areas. So the evaluation of good applies to performance where there's a number of important strengths which clearly outweigh areas for improvement. So it's good, but perhaps not good enough. So that whilst the strengths have significant positive impact on people's experiences and outcomes, improvements are still required in order to maximise people's well-being and ensure that they have experiences which are consistently as positive as possible. So in terms of next steps, so the partnership has shared the findings and outcome from the inspection, and highlighted to relevant partners that the inspection report has been published. It's published at the end of November. We are in the process of developing an improvement plan to address those 5 areas for improvement that were identified, and so that improvement plan will first be remitted to the clinical care governance meeting, and will then be shared with the care inspector, who will maintain oversight of our improvement work. And in addition, the findings from the inspection have already begun to inform the ongoing work around the redesign of our in-house care at home service, the commissioning framework for care at home services, and the how we implement self-directed support within the partnership. So thank you. I'm happy to take any questions.
Okay, thank you, Daniel, for that presentation and that very full report on the Inspectorate's report. Can I just ask, first of all, you made mention that Falkirk was ranked highest in terms of levels of care at home improvement, but I didn't see any kind of benchmarking on that. How did they come to that conclusion?
So there's national reporting arrangements. So data collected by Scottish Government. So a large part of the inspection process is looking at that data and making comparisons and benchmarking against that national data.
Right. So that's not in the report though, but it's separately done.
It's included as part of the inspection. I think there's probably reference at the end of the report to of the actual inspection report to the data sources.
Okay, I'll have a closer look. Thank you. The other thing I wanted to ask about was the five priority areas for improvement that are identified. I don't think any of these will surprise any of us in that these have come up on numerous occasions as areas for improvement. How are we going to be assured that this time serious activity is going to take place to do something about this, and it's not just going to keep coming up forever and ever and ever?
So the improvement plan that the Care Inspectorate will oversee, I mentioned earlier, will come via the Clinical Care Governance Management Group. So that improvement plan will need to be agreed with the Care Inspectorate, and they will maintain monitoring oversight as well as the committee through CCMG. I think you're right. None of these areas were a surprise, and we've already begun to address the majority of them. So in relation to self-directed support, for example, we've begun to look at how we build on the recent introduction of the self-directed support policy, and how we raise awareness amongst social work staff in particular to build their confidence in offering all four options with equity, which is how the statutory guidance would urge us to do. And we're already looking at the issue around hospital discharge, how our framework enables us to have the flexibility to enable people to remain with the same care provider if they're in hospital for longer than 7 days. So just exploring all of those different ways that we can make early inroads into those improvement areas, and we'll continue to report to those report on those matters to CCMG, and can come back to this committee as well if that would be helpful.
Okay, thank you very much. Roger?
Just looking at the possible discharge pathways improvement. When the framework was introduced, all my colleagues were pulling their hair out and saying, this is crazy. Our clients frequently go in and out of hospital every year, and every time they're going in and out of hospital, they're going to have a change in carers. They need consistency, this consistency that are keeping them out of hospital, and instead all the colleagues felt they were just not listened to. So I suppose this is a plea to please listen to people in these circumstances, because we could have avoided this. Thanks.
Daniel?
Thank you, Chair. So absolutely take your point, Roger. The impact on people of needing to change provider, it can be really significant. People might have had the same care provider for a number of years, built up really strong relationships with staff, and then a spell in hospital, and then needing to change to a different care provider can have a really significant impact on people's ability to I guess maximise their independence once they're home. So I think the framework has brought about lots of capacity in terms of the independently commissioned care, but perhaps insufficient control. So we're looking at the next iteration of the commissioning framework, which will So the current framework is due to be extended for a year until 2027. And we've been looking with internal colleagues and taking legal advice around what we have scope to do to address those issues before the expiry of the current framework.
Okay, thank you. Anyone else got any questions or comments? I think this is kind of rather a major piece of work with major kind of long-term implications. Just a plea to, in all the things that you're looking at, to have a very person-centred approach. Because I think sometimes one of the problems is that we have in this whole system is too much of a system-focused approach and not enough a person-centred approach. So that's my plea. That's at the top of every page, person-centred approach. Any other comments or questions? If not, we will look forward to further reports on outcomes. We'll go back to the recommendations. So we've noted the inspection findings. Note that an improvement plan is being developed, and once this is approved, it will be overseen by the Care Inspectorate. And note that oversight and monitoring of the improvement plan will be remitted to the Clinical and Care Governance Management Group. And I assume there will be report backs to the Performance Audit and Assurance Committee as and when that is necessary. Don't know if that needs to be added. Maybe as well to be added.
I was just going to say, so those updates will probably come through the Clinical and Care Governance Group update reports that come anyway. So
right,
thanks.
So that's already in the system. Okay, thank you. So can we agree those recommendations then as they stand?
Agreed.
Yes, thank you. We will move on then to the delayed discharges deep dive. And I think that will be Caroline that's going to do this. So if you would like to lead us through this report, please. Which we have kind of put off things on other reports pending this rather meatier piece of work.
Thank you, Chair. Just to mention as well, I've also got Claire Chapman joining us online, who is the Home First Lead and oversees our work around hospital discharge. So I'll talk through the report, but just I may bring her in at points to support around questions that may arise. So this report provides a comprehensive deep dive into our delayed discharge position. I'll take you through the key points across the main sections. I'll begin with a summary of the national context and our local performance before highlighting recent improvements in our standard delays, the challenges and progress relating to complex Code 9 and AWI cases, and the wider pressures evident across the whole system, including emergency department activities, which we touched on earlier. I will then outline the improvement actions underway and the implications for future service delivery before concluding with the key messages for the committee's consideration. So starting with the background section, the national findings are outlined in the National Audit Report, and they're covered in sections 1.4 to 1.3 in the report. The National Audit Report, Delayed Discharge as a Symptom of Challenges Facing the Health and Social Care System, was published in January 2026. The full report is available in the appendix. The key highlights from this section include 1 in 9 hospital beds nationally is occupied by someone who is medically fit for discharge. Nearly 18,000 people experienced a delay in 24-25. This represents around 3% of all inpatient discharges. Older adults aged 75 plus account for 2/3 of delayed bed days. And delays due to adults with incapacity legislation requirements are significantly longer, often ranging from 12 weeks to 6 months or more. These national findings help frame Falkirk's local performance. So moving on from section 4.4 to 4.11 in the report, the local context is outlined. The key message is that Falkirk's trends mirrors the national picture, but with recent positive movement. Key points are locally 2.9% of the discharges in 24-25 involved a delay. This is slightly better than the national average of 3.2%. Table 1 shows a 19% increase in demand for discharges from 2007 to 2024. And chart 1 shows that Falkirk's delays rose after COVID, but have recently declined sharply, particularly for standard delays. Moving on to standard delays, which are covered by 4.12 to 4.18 in the report. Standard delays relate to people medically ready to leave hospital, but waiting for care at home, care home placements or assessment. Chart 5, just before 4.17, highlights a key improvement. Standard delays have remained below 50 for 31 consecutive weeks for the first time since 2022-23. The contributing improvement actions are summarised in this section as Shifting the Balance of Care project, which commenced in June 2025, additional assessment capacity, both within our reach and social work teams, the funding of 16 interim care beds at New Karen, which have been used to support movement around the whole system, 2 housing-based interim solutions within Housing with Care, and increased social care capacity through the winter funding. It's recognised this list is not exhaustive and there are wider whole system improvement works that have also contributed to this work. Combined, these actions have positively contributed directly to improved flow and reduced contingency bed use. Turning to Code 9 AWI delays, which remain the most significant challenge for the partnership. These are summarised in 4.19 to 4.25 in the report. A Code 9 delay refers to a complex discharge where someone is medically ready to leave hospital but cannot be discharged due to legal, clinical or special care barriers. The most common cause is delays due to adults with incapacity legislation. As outlined in this section, Falkirk has experienced historically high levels of AWI-related delays, rising significantly between June and November 2025. Chart 6, just below 4.23, shows a clear improvement from November onwards following targeted actions that were implemented. Improvements included putting a dedicated MHO resource into the Home First team, daily AWI reviews and improved case tracking, enhanced governance around these cases, strengthened links with our legal services, and training and guidance updates, along with improved recording systems. Falkirk is also represented in the National Improvement Group for Complex Delays. These actions have led to measurable improvement, although AWI delays remains a significant ongoing challenge across a number of partnerships, including our own. Moving on to emergency department pressures, which are covered in 4.26 to 4.28. This section provides important system context. Chart 7 at 4.26 shows lower ED attendance, but Chart 8 shows higher admission conversion rates and the poorer 4-hour performance relating to increasing complexity and high bed occupancy. This reinforces the importance of maintaining improvements in discharge pathways and feeds into the development of the proposed integrated discharge service that the partnership, in collaboration with acute colleagues and colleagues from Stirling and Clackmannanshire Partnership, are currently exploring. So turning to section 2, the recommendations are the committee is asked to note the findings of the National Audit Report, note the sustained improvement in standard delays, and note the progress in addressing complex delays, Code 9 AWI delays, and to endorse the continuation of the improvement work streams that are strengthening our approach to pathways and system flow. I'm happy to take any questions, Chair.
Okay, thank you, Caroline. Thank you for this deep dive. And clearly, this is an issue, the delayed discharge issue is fundamentally important in terms of our whole system, and it needs to be addressed. Can Can I just, before I open it up, ask for a wee bit of clarification? I did mark it on my papers and I can't see it now. Yes. I mean, it says the key points in the report says on average 1 in 9 beds, that's 11.7%, are occupied by someone medically ready to leave. Yet it's saying that only 3% of inpatient discharges are delayed. I'm kind of trying to get my head around that. If 11% of the beds are occupied by people who don't need to be there, are they not all being delayed in some way? This is back at 4.3, sorry, I should have said that. Can you clarify for me?
So this is in reference to the national report,
Yes.
completed by Audit Scotland. So the majority of discharges are not delayed. The majority of people that are fit for discharge are supported in a timely fashion, so wouldn't be coded as delayed. But there is a number of people that, so on average 1 in 9 are occupied by someone ready to leave. So it doesn't mean that they're actually delayed in hospital. So it's just about, I'm probably not explaining it well. Trying to think the best way to explain it.
So I think Gail has her hand up as well. Perhaps she could clarify.
Yeah, so I think it probably relates to if people have significant complexities in hospital and they might need quite a high level of care package when they come out to the community, they're more likely to be delayed in the discharge, but they're more likely then to have a longer length of stay. So you might have a lot of people going in and out of hospital just for and having a few days in the hospital, but you might have a number of people that are, have significant complexities and they're maybe there for quite an extended period of time. And I think that's why you'll see that the number of people delayed is 3%, but the number of beds occupied is closer to 10%. That'll explain the difference in it. On the surface, it looks strange, but that'll explain why it's shown in that way.
Okay, thank you for that clarification. Does anyone have any? Sorry, Roger.
Yeah, just obviously most people in hospital for just a couple of days. So if somebody's delayed in hospital for 3 months, that's effectively taking up a bed for each of those 2-day people, 2 or 3 days people. That could be 10 or 15 people that haven't been delayed, could have taken up that bed. Does that make sense?
Yeah. I think I'm grasping it. Any other comments or questions? Roger again, yes.
Yeah, thanks, Chair. Just on a different point, people know that I'm a mental health officer, and probably about a third of my work is around delayed discharges for AWI, Adults with Incapacity Act delays. And so the team of mental health officers were quite disappointed by aspects of this report. That it wasn't very clear and wasn't very helpful. I'll give you an example. It says there was an appointment of a dedicated mental health officer. Now, I'm a dedicated mental health officer, and a number of my colleagues are dedicated mental health officer. So that didn't really explain in the report why this extra person, Phil, was making any difference, and I felt it could devalued other dedicated mental health officers. So I felt that would have been quite useful to say, well, what was the purpose of these targeted improvements actions, and what made difference and what didn't. And in fact, my colleagues probably felt that they haven't been listened to once again. And maybe coming down to people on the front line and saying, what do you think would make a difference? Because actually, it's if you know the system, it's a fairly long line of a lot of different issues all along it to go from the start point of somebody with incapacity or deemed to have incapacity to the point of how long they've been delayed, and going through the legal system, and it can only take one fragile bit of that line to break down, and suddenly you've got a whole load of extra delays which can skew the statistics up quite badly suddenly, and that then can even off when that problem is resolved. So, for instance, one person can go off sick, and that can make a huge difference to the stats. So it's quite a fragile system, and I think that's something which I think would be really useful to get your head around a bit better, and I think it would be quite useful to come to the front line and say, "Oh, what do we think is going to help this fragile system more stable and more robust?" Thanks.
Can you address that, Caroline, please?
Thank you, Chair. So if I maybe start first with the wording dedicated, what we mean is it's a MHO that is working only in the Home First team. So I'm quite clear that all, our workers that work within social work services are committed to their job. So maybe dedicated is the wrong word. What we're saying is exclusively they work within that Home First team, within that support and that pathway. In terms of involvement from mental health officers, this work has been overseen by the team manager for the mental health, MHOs, who is your direct line manager. And I would expect that he's taken information from frontline MHOs because he is well aware of the challenges and the issues that certainly that team and that role faces, because it's not just exclusive to the mental health team, that role. Having worked as an MHO myself, I totally understand the challenges around it and the complexities around the piece of legislation. What I would say is by having putting an MHO resource into the Home First team, what that's done is it's strengthened practice of the social workers within the team and that kind of connection with other stakeholders when you're planning discharges for people that may lack capacity. So what it's doing is actually probably supporting people at an earlier stage rather than waiting for that formal, assessment. And I think that's been a real positive around that role. Part of the reason why we tested putting that role into the team is because national feedback was telling us that is best practice, that other areas that have succeeded around improving performance in that area, one of the key factors was the fact that they'd put an exclusive MHO resource into a hospital discharge team. So we were drawing on both best practice, but also drawing from across the systems in terms of getting advice and guidance. So hopefully that summarises and explains a bit better the role and the impact that it's had.
Okay, thank you, Caroline. I think we have David McNiven next.
Thank you, Chair. I'm been on holiday this week, so I haven't had too much time to look in detail these reports, but there's two questions, one on chart 7 and one in chart 8. Would it be helpful to have chart 7 segmented into knowing how many people attend A&E by ambulance or walk-in or by referral from GP or 111? It would indicate, give us an idea of people's thinking and behaviours, perhaps. And in item chart 8, is that, correct me if I'm picked this up correctly, does that mean that more people are being admitted from A&E? Does that mean that the population is becoming sicker, or the hospital, which is effectively a sickness management system, got new skills that's applying that we perhaps don't know?
Alan?
Thank you for the question. In terms of chart 7, I think we could certainly pick that up. It's something, I think Callum is no longer here, but that's certainly something I can. So Callum obviously supports us around pulling together this information as a performance manager. So that's something that we can pick up and maybe look at how we can share that information within the performance report. In terms of chart 8, you've read it correctly. I don't know. I guess we would need to do more interrogation of the figures to really look at the reasons why. But yeah, you're reading it right. What that means is more people are being admitted following presentation at A&E.
Okay, can I ask a supplement? Okay. I'm beginning to think there's an option for us in the future to consider the kind of principles behind supply chain management and looking at, it sounds very businessy, but I apologise for that, for managing the processes. So if the hospital is deemed effectively a factory and it's improving its productivity, is it doing that in conjunction with planning with us in terms of what their post-factory healthcare requirements would be, if that makes sense?
Caroline, and I think I've got Claire and David, Dr. Heron, who also want to come in this same subject. So you first, Caroline.
Thank you, Chair. So I would provide assurance to the committee that we work really closely with acute colleagues, as well as like Stirling and Clack's partnership. But, you know, we have to collaborate closely to address these whole system challenges, because while these figures focus on the people that are presenting at accident emergency, I guess I would reference the previous discussion we had earlier on in the committee. You know, these are really whole system issues, and we need to really make sure that we've got that flow throughout the system, but also have the right service at the right time being delivered. And that's really what we're working towards around some of the plans that we've referenced today. But I don't know if Claire would maybe want to come in around this.
Claire, do you want to add to that?
Yeah, thank you. I think they're really excellent points around those charts. Certainly for assurance, we are involved as a partnership together with acute colleagues on looking at that admission data and actually looking at the range of attendances, because that's supporting us with how we're managing and supporting the work, for example, in the frailty unit. So we're looking to embed some approaches just as part of the integrated discharge service. That's also helping us around our admission data and who's been admitted from where. So you're absolutely right in terms of those pathways into that front door area. But I suppose what we're recognising is how we are looking at the data, and our data is getting better all the time around how actually, you know, we see those surges and presentations and maybe what's informing that and how we can predict that a little bit better. So for assurance, that is something that I'm working with acute colleagues in. And I think certainly culturally, in terms of how that whole system is operating and changing and evolving, that's becoming more together. So that's certainly a piece of work that I'm involved in.
That's super. Thank you very much.
Okay, thank you, Claire. David, Dr. Heron.
Yeah, I think Alison was before me.
Sorry. Oh, sorry. I have trouble seeing the hands from this distance. Alison?
And I just wanted to come in on the complex discharges and the adults with incapacity, because while they may be smaller figures, they have a big impact on the system. And it's been a figure that since I've joined the board, I've been kind of watching. The others move and it stays stubbornly static. And I think just listening to the conversation today, it is great that we have done some things to move it, but are we putting enough attention into this, given the impact it has on our patients' lives and across the system? Because it is a smaller number, but are we giving it enough attention, I guess is my question.
Caroline, do you want to come back on that? Or?
Yeah, so thank you. So in response to the increasing figures around this, we recognised that we had to do a concerted piece of work around this, but this needs to be long term. We need to make sure that we're embedding this as business as usual. And around our development work, what we're keen to do is make sure that we continue that scrutiny and drive around AWI so that we can get to a point that where possible, no one is delayed down to the complex reasons down to AWI. One of the things I think we do need to look at is how do we promote the use of power of attorney. So in the national group that I'm part of, really what I'm doing is that I'm kind of putting that challenge out to Scottish Government to look at, because I actually think you need a national campaign around this. And if you look at the impact of the national campaigns previously, it supported uptake of power of attorney. And it means then people aren't getting stuck in a system. It's costly. It's time consuming if someone's having to make an application for guardianship. Whereas if they've already nominated someone that they feel more comfortable around, being able to make their choices around their welfare and what they would like to happen in the event that they're no longer able to do that, I think that's more keeping with the principles of the legislation, and improving outcomes for people so that they're not in the wrong place, at the wrong time, that they're in a more homely setting and getting the care and support that's more appropriate to their needs. So I would just provide that reassurance that we, both myself and Claire, have got clear plans around that and how we would take it forward.
And I'd really endorse that. I'm a big advocate of that with all family and friends and everyone I know. I have that conversation about wills and powers of attorney. But I do wonder if there's something we can do more locally with our carers group, some of the third sector that we work with to promote this, because it does have such a big impact rather than waiting on a national solution, given the impact it has on families and patients.
Yeah, I mean, I think that there is some work going on in that, and I've been at the carer centre where they've had discussions about power of attorney, and people in talking to them about how to progress that. But I think, yes, I mean, there is a question about how much is within our control and how much requires legislative action or action by others, and we have to do those things that are within our control and shout about the things that are somebody else's job. Claire, do you want to come back in on that one?
Yes, it was exactly that point. Thank you, Chair. So I absolutely agree. I think having this worker with the scrutiny over these particular cases as a dedicated resource, it has shown that we've identified some local issues that we absolutely do have control over. And as part of that post, it's supported in coordination and robust oversight, taking Roger's comments into account. I think, we do have mental health officers that are absolutely working daily on these with patients around guardianship applications. But I think what's in our gift now is that oversight, scrutiny, and making sure that we've got that momentum in relation to our policies and procedures in place. I think what this work, you've mentioned quite rightly, this work's identified national issues, around, for example, within our local court systems, within our court rates, within varying and different new sheriffs that may come, around different decision making and how that impacts patients as well. So I think it is absolutely shining a light on local and more of those national issues that I think other partnerships are also experiencing, and certainly Caroline and I are involved with Scottish Government colleagues around, escalating that and having good discussions about what may be possible in that area and support. So I think that was a good point. Absolutely.
Okay, thank you very much. I'll come back to you again then, David.
Thank you. I was really interested in this report, and it does speak to some of the complexities that Gail mentioned earlier when I made the comment about delayed readmission rates. I was really quite interested, similar to David's comments, around what the charts show us. And I think sometimes we get charts that show Falkirk data, and sometimes we look at charts that are Forth Valley data, and it can be quite hard. David asked a question about what percentage of admissions come through A&E. So the data suggests about 50% of people who are discharged come through A&E. There was a big increase, 20% increase in discharges, and I wondered how much of that is accounted for because of the higher 28-day readmission rate. So it's not individual discharges, it's total discharges, because people are being discharged twice if they get readmitted within 28 days. There's a higher conversion to admission rate, and I think that's because people are presenting with higher acuity, which has been reported since COVID for some reason. And I think that does strengthen the argument here for improved access to preventative care in the community before admissions, including general practice. People need to present with their illnesses earlier so that we can try our best to prevent things in admissions and escalation. And it also speaks to the sort of contribution of wider improvements to people's health in the community, so third sector and and the council's role in keeping people healthier before they get admitted to hospital. And I think all of that might have something to do with the increased acuity that we're seeing now that we didn't see compared to 10 years ago. So I think this does give a strong argument. I think if we only focus on the delayed discharges rather than focusing on the front end of the system that's struggling, then that would be a mistake. Thanks.
Thank you for that, David. Absolutely agree. I think everybody on this committee will know about my passion for talking about early intervention and prevention rather than dealing with the problem once it has arisen. I'm not sure if anyone wants to come back on that point, or if that was, if there was, I didn't quite hear a question in there, David. It was more of a plea. But if there's a question that somebody wants to answer, please put your hand up. I think Gail has her hand up for that.
So I'm probably going to make some general comments which will touch on some of the things David said, but I'll probably let Councillor Flynn come in first.
Okay, Councillor Flynn.
Yep, thank you, Chair. It was just really more a comment on the fact that power of attorney was mentioned. I think we're sure we'll all agree it's very important to have this set up proactively, not when we need it, so it's there when we do need it. So I think there's an opportunity for ourselves through the comms to do a wee bit of promotion on that. Maybe it's already happening to try and encourage people. But the other aspect of it, I think, is quite important. There's a cost factor related to that. You know, it's all very well saying people should set up power of attorney, but it's not cheap. It costs a wee bit of money to get a lawyer of that set up. So perhaps in some way, maybe the carers organisations or whoever could work with local lawyers and see if there's any, I don't know, beneficial terms, not promoting the individual lawyers, but just saying, look, with this category of individual who can't afford it, is there an opportunity? You'll see sometimes through different charities, free will services. So I'm thinking an opportunity of a similar system, because the more people it strikes from the conversation that have power of attorney, it kind of smooths the journey or the activity that we're trying to achieve. Thanks.
Okay, thank you, Jim. I think Tom wants to come in on that point. Or is it a new point you've got, Tom?
No, it is on that point about power of attorney. I can understand the public perception around about the complexity and cost around about power of attorney, but actually there are a lot of myths and legends about it as well. And actually, you don't actually need a solicitor. What people will tend to think they need a solicitor for is to draw up the power of attorney. But there are plenty available templates which are actually very easy accessible. And in fact, I did one myself not so a few years ago, and has been used by a number of different people over the time. The important thing is the validation of that template once it has been completed. And actually, a solicitor is only one of two options there. But I would suggest that the preferred option is actually your general practitioner. Now, of course, yes, you would need to get a private appointment and pay for that. A lot cheaper, I have to say, than a solicitor. And in fact, who is better able to assess somebody's contemporaneous capacity than their GP, or rather than a solicitor who will see this through a legal framework provision. So again, if we're going to go out and promote this, I think what we ought to do is to ensure that we're giving really good grounded advice to people that's accessible and is affordable. It really is not an expensive proposition here, and can be done quite readily with tools that are online, and just support.
Thank you very much for that, Tom. I think Victoria wants to come in at that point.
Yes, thank you, Chair. I have a couple of points, particularly the first one around power of attorney. So the third sector, and particularly CBS Falkirk District, worked hard every year to run a campaign to support and encourage people to complete their power of attorney. And we do that with the Office of the Public Guardian and other third sector partners. We also have, based within Falkirk, the Solicitors for Older People. This is a partnership across Scotland where many solicitors come together and provide preferential, not just rates to complete their power of attorney and their will, but to provide reasonable guidance through all matters right through to end of life care as well. And I can certainly put you in touch with that. We work closely with Adult Support and Protection Team, and in fact last year we held a conference in Forth Valley College. I think Gail came along to that conference, where not only did we promote power of attorney, writing your own wills, but supporting adult support and protection and all of the other complexities that go around that. And I'm more than happy to speak to partners about possibly hosting another event. This year we had planned to do it on a biannual year because, as you can imagine, I don't always have money sitting in my bank account for conferences, but I'm more than happy to look at it to do something this year because it's been highlighted as a priority within this board. The other point I was about to make was about delayed discharges. So I'm more than happy to speak with colleagues about potentially third sector support with regards to delayed discharge. I certainly created different projects probably about 10 years ago, one of which was the HELP project, Home Essentials Leaving Pack. So that was to help those people who had delayed discharges because they couldn't get their care at home package in time. And it was to do that intervention to support the first 3 days of them getting home. So I'm more than happy to talk to anybody about that as well. So please just get in touch with me if you want more information.
Okay, thank you for that offer, Victoria. I think there's kind of a number of offers in there that maybe need to be taken offline rather than investigated here. And I wonder if there's a case for looking at the comms as well on our Health and Social Care Partnership website to look at what links we could put in there and look at what things could be done there. Sorry, Gail, you've been patiently waiting.
Yeah, I just wanted to really sum up. So we're focusing on delayed discharges, and as David says, and as we spoke earlier, delayed discharges is one part of the system, and it signals how well one part is working. That one part relies on a whole lot of other parts of the system as well, so it is complex, and it's really important to recognise that complexity. I suppose I really wanted to highlight there has been significant and sustained improvement in Falkirk, and that hasn't just happened by accident. That's happened down to a really good, robust plan and real sustained hard work across the whole system, so including our teams and acute teams and Clarkson Stirling teams. So that's taken a lot of hard work, and it continues to take a lot of hard work. So just really to commend everybody who's been involved in that. It absolutely aligns with what we're doing, aligns with the National Discharge Without Delay programme. So in terms of learning from what works elsewhere and considering how that can be adapted to work locally in Falkirk and Forth Valley. I think in terms of the increasing demand that we are seeing, we also had the recent results of the Healthy Life Expectancy. So we know that people are living for longer in poor health, and that will obviously have an impact on their health and social care needs. So that puts additional demand on our existing services, be that community health services, hospital services and care services. In terms of thinking about early intervention and prevention, so that whole system is really important. Think about what are the pathways that are available for people when they do need a little bit of help to stay at home, stay in the community, have the right supports, health and social care supports at home, to hopefully mean they don't have to turn up at ED. But when they do need to go to ED, it's really important that there is that space available, and that very much relies on the activity across the hospital, including that flow out of the hospital, so helping people get home when they're ready to go home. And in terms of thinking about early intervention and prevention, the longer, and we all know this because we talk about this regularly, the longer somebody stays in hospital when they're not needing acute care, that's not the best place to be. People become deconditioned, so therefore their longer term care needs is likely to increase. So the overall demand on the system increases, which means that we have less capacity in the community for people who really need it. So it absolutely is about early intervention prevention at that part of somebody's journey, that when they're ready to come home, we're able to get them home. So that improvement in processes and systems the work we've done, for example, in shifting the balance of care, and also the capacity we have in the community. We've evidenced the impact that that can make, you know, and working that whole system. So we've had, for example, some slippage money around our urgent and scheduled care, and it's been agreed across the whole system that that's best place with care at home capacity, and that's allowed us to support more people to come home. So that sustained reduction has been visible now. It's been sustained for over 8 months. I think it's we can see a really big step change, and the information you have today, every week I get the latest delayed discharge stats out across the country. It's the thing one of my emails I look forward to the most receiving on a Friday. And there was a time that Falkirk was consistently in the sort of 3 worst integration authority areas. So we were performing quite poorly compared to the rest of Scotland. Today it's come out and we're 5 integration authorities better than the average. Hopefully that makes sense. So it's management data, but we've come on a journey. We've been sitting around the average, and now we're a big step better than average. And that has been down to having a clear plan, all of the work that's been put in across the whole system, and everybody working collaboratively together. So I think it really is worth recognising that, and that ultimately helps improve outcomes for people, which is what we're all about.
Thank you for that, Gail. I think that's a good and positive note on which perhaps to bring that discussion to an end, unless there's anyone got something burning they want to say. I think it is important that we recognise where there has been progress, albeit we know that there's still a long way to go. So I'll go back to the recommendations in the report. So we've been asked to note the findings of the delayed discharges, a symptom of the challenges facing health and social care report from the Audit Scotland, and the alignment of Falkirk's local challenges with wider Scotland trends. Note the significant and sustained improvement in standard delayed discharges in Falkirk, achieved through shifting the balance of care, increased social care capacity, discharge to assess and winter pressures actions, which Gail has just been highlighting. Note the progress made in addressing complex Code 9 or AWI delays, including strengthened governance, enhanced case oversight, dedicated MHO input, improved recording systems and practice development, and endorse the continuation of improvement work streams aimed at further strengthening discharge pathways, maximising whole system flow and developing more responsive services to prevent hospital admission. Can we agree all these recommendations?
Agreed.
Thank you very much indeed. That then takes us to the final item, although I have an item of any other business I do want to address at the end. But the IJB assurance report from this committee, that's what we want to take from this committee, the key issues we want to take from this committee to the full IJB. I usually go at this point to Gail, but I think Ewan's going to pick this up today.
Thank you, Chair. Before I ask the golden question of committee, I'll just do a really brief summing up in terms of what I think we may want to highlight to the IJB through the assurance report. So covered in annual audit plan and discussion on getting back to normal timescales next year. Had a detailed discussion around performance monitoring reporting, including acknowledgement of the delayed discharge improvement, particularly noting thanks to be passed on to all the staff involved in that. Some discussion around telecare and our longer term approach, the monitoring of trends and looking at where work's ongoing around potential invest to save proposals around telecare to continue an improvement trajectory.
discussion around attendance management and that being brought into the financial oversight group. Concerns regarding accident and emergency performance, including numbers leaving hospital without clinical assessment, deterioration of readmission levels and associated concerns. We covered national reports and inspections overview, including key issues from national reports and detail from the inspection report from Ward 5 at Forth Valley Royal within the mental health unit, and the improvement group being established to oversee the improvement plan, and also his report on the whole of the mental health unit was highlighted, and that will be the subject of a future deep dive. Covered partnership funding scrutiny, including clarity on the purpose of the report provided, the need for scrutiny across all areas of spend, including contribution of third sector and wider partners to the whole system, challenges and pressures, and discussion on how we measure impact and evidence of value added, including outcomes. In clinical and care governance management group report, leading us to go through the key points, including deep dive on Keep Well, which will be presented to PAC in June 26, and some questions around and discussion around resuscitation training and the level of risk we are holding compared to other areas of risk in mandatory training, and the importance of corporate parenting training was highlighted. Daniel took us through a presentation covering the integrated inspection of care at home, including the approach, activity, key strengths, priority areas for improvement, effectiveness of care plan arrangements, alignment to national health and wellbeing outcomes, evaluation and next steps, and the need for to continue a person-centred approach was specifically highlighted. Had a deep dive report on delayed discharges, and a lot of good discussion around that, including some discussion around the deployment of mental health officer capacity, the alignment of that to adult with incapacity issues and system process issues, gain acknowledgement around the hard work that has gone into the sustained improvement around delayed discharge was specifically acknowledged, including acknowledgement of Falkirk's performance improvement comparative to other health and social care partnerships, and some specific discussion around how we can align to national improvement work around power of attorney, but also specific actions and thoughts to be considered around how we work with local groups, carer centres, etc., and use of local communications and our own website to support awareness and improvement in activity around power of attorney. So on the basis of all that, I would ask whether the committee are assured by the reports and discussions undertaken today, and to confirm which items they wish highlighted to the Integration Joint Board. Thank you.
I think that was a very thorough and detailed summary of the matters and issues we've raised here today, and I thank you very much for that. Can we agree that we are assured?
Agreed.
Agreed. And can we ask Ewan and rely on Ewan to put his summary of the key issues into a report to the Integration Joint Board? Agreed. All right. Thank you very much for that. I want to say thank you to everyone for their attendance here today, and for that was quite a weighty agenda we had, and a lot of things in it. Yeah, I do want to ask everyone to stay online after we have stopped the live streaming, because there is a small matter we need to address in private. But at this point, I think we can stop the live streaming and say thank you to everyone who has attended the committee meeting. It's going to take a couple of minutes just to ensure